Hello. Hi, my dear lovely friends. A very, very warm welcome to the surgery session. Uh, I sincerely apologize for the unwanted delay today because there was a technical issue which creeped up today morning in the audio of the system at my end. But I hope you all are keeping yourself sound and safe. And just a few things before we start the surgery session. What I would like at my end would be just a moment. Right, my dear friends. So before we start, let us just try to understand that how we have to play this game as far as surgery is concerned. We know that there would be approximately 32 questions from surgery. Now, how we are going to handle those surgery questions? We would be having the workbooks of the surgery class. Those who have joined a little late and those who have not been able to receive their workbooks, they would be having the PDFs. So I hope by the time the books reaches to you, you are able to manage with the workbooks. Basically, in these 32 questions, I believe that we should be able to solve at least 27 to 28 questions in surgery on 17th of December. What type of questions can be there from surgery? Out of these 32 questions, I believe that there would be approximately 7 questions which would be straight direct questions. And those questions would be something which we would be chanting during our classes also, and they would be on our fingertips. Just a moment, let me just check. I'm just looking at the group messages so that if there is any kind of problem, let us just fix this. As of now, I'm seeing that just a moment. Right. So I think I can see a few messages in RBN group. Rest all other groups, the students are not facing any problem, and I hope that RBN group students gradually will try to acclimatize and hopefully they will not be facing too many problems. Right, beta? So we were just talking about that how we have to plan these 32 questions. 7 questions would be something which would be single liner, which you will be able to mark them correctly. A small thing what you have to take care here is please read the words incorrect, not true, except, something like that. Okay, in those 7 questions, because we do not want to commit any silly mistakes in those 7 questions. Now, remaining 25 questions, from where they are going to be asked. Out of these 25 questions, there would be approximately 15 to 16 questions which would be written somewhere here and there in your workbook. But there would be 9 to 10 questions which you will be able to answer by understanding the concepts what we are going to learn in these surgery classes. what the knowledge we are going to gain in these surgery classes, they are going to be the game changer, beta. And I strongly believe that the concepts which you make in these surgery classes, they will definitely help you on 17th of December to crack even those type of questions which may not be the direct question, or which may not be the same language what is there in your workbook. Right, beta? We all understand that the last 5 exams of FMG, the change which has happened is the examiner is not using the same language of the question, what is something which we read in the standard textbooks, but he's trying to just break the language of that line into a knowledgeable understanding. The same thing is happening with the options also. So we need, if we are able to understand what that particular line actually means, then definitely our life is going to be much easier on 17th of December. So beta ji, with folded hands, my request to all of you, beta, that please listen to these classes very carefully, especially the concepts which we are making. We know that these live classes will be available in the app for 24 hours after the class is over, right? So the advantage of online classes, what we can take is that if suppose by chance we are not able to understand a particular concept somewhere, we can quickly go back and we can just re-understand what the faculty is trying to explain, or what the faculty is trying to give the concept to us. Right, beta? Okay. Now, if we take a look that out of these 32 questions, what will be the chapters from where these questions are going to be? Surgery broadly is divided into two things: general surgery and systemic surgery. General surgery is anything which is general, and systemic surgery means related to systems. And the two systems what we emphasize in surgery are GIT and urology. GIT is a system which is mainly dealt in surgery. Urology is something which we keep on discussing in other subjects, maybe pathology, maybe pharmacology, maybe medicine, but surgical urology focuses mainly on the surgical aspects of kidney, ureter, bladder, urethra, and the area around that. Right, beta? So before we start, let us take a look at the indexing and let us try to understand which particular topic will give us how many questions on 17th of December. Right. Right, beta. So this is the surgery workbook what you're having, beta. In this surgery workbook, overall there are 9 chapters. How many chapters, beta? 9 chapters. The first 6 chapters, they are of general surgery, and 7th, 8th, 9 chapters belong to systemic surgery. In general surgery, we talk about trauma section. So from trauma, we do expect approximately 6 questions on 17th of December. Then in surgical wounds, they may ask a question or they may not ask. This time, 4th of June 2022, they asked 2 questions from the small surgical wounds chapter. Plus, there was another question which was actually related to pathology in this surgical wounds chapter. Chapter number 3 belongs to dermatology. So this will be taken up during your dermatology classes. Chapter number 4, that is vascular surgery. We would be getting approximately 4 to 6 questions in this vascular surgery. Endocrine surgery, we'll be getting 2 to 3 questions in this endocrine surgery. Salivary glands, there may be no question or there may be 2 questions from the salivary glands. That means if we take a look at the number of questions from general surgery, let us take this as one question. Then here we can take this as two questions. So 1 plus 2 is 3. Then 4 to 6, let us take it 5. So 3 plus 5 is 8. And since this belongs to dermatology, so let's give this to dermatology. 8 plus 1, 9. And 9 plus 6, 15. That means you'll be getting approximately 15 out of 32 questions from general surgery. Remaining 17 questions will be from systemic surgery. That means chapter 7, 8, and 9. Generally, the distribution of questions, what we are seeing, is somewhere around 45% from general surgery and 55% from systemic surgery. Though both carry equal weightage for us because each and every question is going to be crucial for us. So now if we take a look at the systemic surgery, this type of indexing of systemic surgery is not available in any textbook across the globe. The reason for segregating the systemic surgery into three topics, that is pediatric surgery, adult surgery, and elderly surgery, is that the questions which you are getting on 17th of December, especially when we talk about the clinical subjects, beta ji, these clinical subjects, they are, you are given the age of the patient. You are given the site of symptoms of the patient. Plus, when you will be practicing as a big doctor, you will be seeing the patients of different age groups, right? So whenever a surgical patient comes to you, just by looking at the age of the patient, you are able to segregate whether this story belongs to pediatric surgery or adult surgery or elderly surgery. The same thing you have to apply on 17th of December also. Plus, what I have tried to do is, I have tried to go in a sequence. For example, when we are talking about pediatric surgery, we are going from top to bottom. First, we are talking about the face, then we are coming towards the neck, then we are going into the thorax, and then we are going into the abdomen. In the abdomen also, we will be going in a sequence. First, the top of the abdomen in the center, that is epigastrium. Then we'll be talking about the right upper abdomen, that is right hypochondrium. Then we'll be talking about the lumbar region, that is the flank area. And then we'll be going into the right lower abdomen, the iliac fossas. And then in the center of the lower part of the abdomen is hypogastrium. So we'll be talking about the hypogastric stories in that sequence. And then we'll be talking something about urethra and penis and the scrotum. So that is how the sequencing has been done in pediatric, adult, and elderly surgery. Now here in adult surgical problems also, you can see we are going to start from top to bottom. First we'll be talking about the topmost area, that is the pharynx area or the esophagus area. So we talk about dysphagia, then we talk about some surgical chest pain stories. Then we go into the abdomen, again in the same sequence, beta G. First we talk about the center top, that is epigastrium. Then we move into the right upper abdomen, so right hypochondrium. And then we move into the lumbar region, that is flank region. Then we move into the right lower abdomen, the iliac fossas, the right and the left side, the inflammatory bowel diseases, and the diverticulosis of colon. And then we go into the center of the lower abdomen, that is hypogastrium. Then we talk something about the groin area and the scrotum, that is the hernias. In the scrotum, we talk about testicular problems. Then we'll be talking about the penile problems, and then we'll be turning the patient in a prone position, and we'll be talking about the rectum and anal canal. So that is how the sequencing has been done, so that it may make your life a little bit easier on 17th of December, just by looking at the question, what is the age of the patient, what is the site of symptom of the patient, you are able to have a nice differential diagnosis in your mind that what can be this pathology. Many a times as a student, we do get confused in choosing the two options. So, if suppose you have sorted out, you have ruled out two options and you are left just with two options where you have to think, and suppose the age of the patient is mentioned there, then it becomes really easier for you just by looking at the age, whether this belongs to a pediatric age group or to the adult age group, this may help you in ruling out those turbulent areas when you have to choose the correct answer between two options. And then finally, the elderly people, where we see a lot of cancers. So in this cancers, because all the cancers are actually having a similar concept, so this understanding of the concept is going to be very, very crucial in oncosurgery. And I'm pretty sure, beta, when you are attending these lectures, I'll try my level best to make these concepts as simple as possible for you, so that if you have that understanding, you will be able to solve these cancers questions as well. So in oncosurgery, first we'll be talking about the GI cancers. In GIT, the relevant cancers would be esophagus, stomach, the colorectal cancers, and the anal canal cancers. We'll also be talking about gallbladder and pancreatic cancers in GIT. Then we'll be talking about urology cancers, where we'll be talking about kidney, bladder, prostate, penile and testicular cancer. And finally, we'll be talking about the endocrine cancers, the thyroid and the breast cancer. We all understand, beta, that breast cancer is the commonest cancer in females worldwide, and prostate cancer is the commonest cancer in elderly males. And both prostate and breast cancers, they are related to hormones, right? Like prostate cancer is related to androgens in males, and breast cancer is related to estrogen in females, right, beta? How many questions do we expect from these three chapters of systemic surgery? Pediatric surgery, we would be getting approximately 4 to 6 questions. And the most major topic in surgery, the lengthiest topic in surgery, is the adult surgical problems, where we would be getting approximately around 14 to 16 questions. Sometimes the range is 11 to 19 as well. Okay, so we do expect somewhere around 14 questions from this adult surgery, and oncosurgery we expect approximately 4 questions, right? So now if you look at the distribution, we were just left with 17 questions in systemic surgery. Suppose we take this pediatric as 5, adult as 15, so 15 plus 5 is 20 already, and 4 from oncosurgery. So this makes 24. Now 24 in systemic surgery and 15 in general surgery, that makes approximately 39 questions. Here I would like to tell you, beta, that though there will be 32 questions from surgery, but when we read this systemic surgery, we actually try to integrate this systemic surgery with so many other subjects, maybe anatomy, maybe radiology, somewhere with orthopedics, somewhere with pathology. So we expect that these many questions you will be able to answer nicely on 17th of December. Right, beta? I do understand that you are having a big responsibility on your shoulders, and I just request all of you with folded hands, beta, please listen to these classes very carefully, try to understand the concepts, and if you have any doubt anywhere, do write in the chat section of the of your batch in the application. If you're not able to mention your queries there, you can note down my WhatsApp number. This is my personal WhatsApp number. You can even send your queries to me on my personal WhatsApp at this number. I do not use Telegram, so I just prefer to answer the queries on WhatsApp. Right, beta? If by chance I miss out on some query, I will try my level best to answer your queries within 24 hours. But if by chance I miss out on some of the queries, do not think that I'm not replying to you. Please ping me again. Maybe I might have missed your query while scrolling the WhatsApp chat, right? Okay, so this is the basic overview. Now, if we try to understand that how we have to move in this surgery. So the first chapter is trauma. Before we start this trauma chapter, beta, I would just like to share the indexing here. Now here in this, what you're seeing, first we'll be talking about the principles of trauma surgery, the primary and secondary assessment stories. And here also, beta, as you are able to see, we are going to move in a sequence. First the head, then the face, then the neck, then the chest, then the abdomen. Okay, so we'll be talking about these traumas in a sequence. Shock, some important relevant things related to shock, hemorrhage, blood transfusion, and finally we'll be signing off this trauma section by discussing about burns. So before we start, beta, I would just like to give you few important concepts here. Just listen to me carefully. Look at me on the screen, beta, okay? First and foremost lesson in your clinical subjects. You are going to be a big doctor. And we all know in our country, India, you are also called as a second God. आपको दूसरा भगवान भी माना जाता है. That means you have really got a big responsibility on your shoulders, because there is nobody else who is responsible to save the life. You can save the life. So the first and foremost lesson what we need to learn here is, we as doctors are supposed to save the life of people, right? In a trauma patient, how to save the life? When we keep on reading the books, we keep on trying to understand what the books are trying to tell us. But actually speaking, beta, if you just close your book and you just try to understand what is the simple common thing. Let us imagine that if we have to save the life of a person, the most important thing for life, why we are able to live, हम लोग जिंदा कैसे हैं? क्या चीज है? What is that thing which keeps us alive? The most beautiful thing on this planet is oxygen. We all have seen in COVID times that how the importance of oxygen was there. You might have seen in the news channels here and there in different countries that what is actually happening to the oxygen, what the governments were trying to do. They were trying to create those oxygen plants. They were trying to transport the oxygen from here and there. As for example, in India, we do remember that the Railway Ministry of India started the oxygen trains. And then the oxygen was taken by train from one state to another state where there was more requirement. And then from the railway station, it was distributed to the different hospitals. And those trucks which were carrying that oxygen, they were even escorted by the police just to deliver that oxygen into the respective hospital. Because inside the hospital, there were so many patients who were dying just because they did not have the oxygen. As soon as the hospital reached that, as soon as the oxygen reached into that hospital, then the oxygen was put in the oxygen pipeline, and that pipeline was going to different patients. That means the oxygen was able to reach to the patient. My dear lovely doctors, if oxygen is there right in front of us, now we doctors have to ensure that this oxygen is going to every cell of the body. And as a common sense beta, we do understand what is the track of this oxygen. हम oxygen कहाँ से लेते हैं? We take this oxygen from our nose and from the mouth. And then God has given us this beautiful airway wherein there is larynx, there is trachea, and then there are bronchus, and then this oxygen is going into the lungs. Lungs are air balloons. हवा के गुब्बारे हैं. This is how the oxygen is traveling into our lungs. When this oxygen comes in the alveoli of lungs, God has given alveolar membrane which is connected with the blood vessels, and at the alveolar membrane, the gaseous exchange occurs between the lungs and the blood. And that is how the oxygen goes into the blood. Now these blood vessels, beta, these are just the pipelines which are responsible for distribution of this oxygen, and there are veins which are responsible for bringing the deoxygenated blood. So we are just trying to ensure the delivery of oxygen, beta. Now, once the oxygen has come into the blood, we know what is there inside the blood, the RBCs. And RBCs is having the hemoglobin. So this oxygen binds with the hemoglobin, and that is how this oxygen is distributed to every cell of the body. My dear friends, what is written in the books? It is just a simple common sense that in any patient, if the patient is dying, we have to ensure oxygen delivery to every cell of his body. And if we know this simple tract, we have to simply manage this tract. हमारे देश की सरकारों ने क्या किया था जब कोविड हुआ था? What the governments did when COVID happened? They just tried to ensure that oxygen is reaching the hospitals or not. If they were able to make sure that oxygen is reaching into the hospital, then it was the duty of us doctors that how this oxygen has to be delivered to every cell of the patient. And if we were able to do that, then we were able to save our patients. Right, Beta? When we have to save the life, we keep on talking about the primary assessment things, the A, B, C, D, E. A for, yes, beta, please speak out, speak out, speak out from your vocal cords. A for airway. B for, yes, speak out, breathing. C for circulation. Very good. D for disability. E for exposure. You know, my dear friends, 4th of June 2022, they asked a question, what does D stands for in A, B, C, D, E? So, beta, what does D stands for? Very good. Disability. Right? Fine. If we have understood the concept of oxygen delivery to different cells of the body, beta, there is hardly anything which you have to revise in this workbook. As a doctor, you have to ensure that the entire tract of oxygen, right from the mouth to nose to every cell of the body, that tract is patent or not. That tract is able to deliver oxygen or not. If not, you have to intervene and you have to secure that particular thing, right? Let us talk about a situation wherein, suppose 17th of December is your exam. You will be clearing that exam for sure. You will be getting your results by 31st of December. In the month of January, you will be getting your passing certificates, or maybe early February. Then you will be applying in the medical council with that passing certificate to have a provisional license to practice. And then you'll be working in different hospitals. So let us imagine February 2023. You will not be attending this class, but you'll be working in the hospital, my dear doctors. And you will be wearing that prestigious white coat and stethoscope, the most valuable thing, what we are reading for. Now just imagine yourself, close your eyes and just try to imagine, beta, that you are actually sitting in the emergency of the hospital. Suddenly you receive a phone call that there is a building collapse near to that hospital. How you have to react to the situation. As soon as there is a building collapse in your hospital, under you, there will be quick response teams. These quick response teams comprises of the paramedical staff, maybe the ward boy, the staff nurse, or maybe the ambulance driver. Immediately you will send these quick response teams to the disaster site where the building has collapsed. And the job of this paramedical staff team is to just give the first aid to the injured people and transport them back to your hospital. Now, when these patients are transported back, for example, let us just try to understand this with different images. Suppose this what you're seeing beta here. Now here what we are seeing, there is a team of paramedical staff. This gentleman, this is a paramedical staff. Suppose this team has gone at the disaster site and they're just trying to give the first aid to the injured people. First aid can be if suppose the airway is getting blocked, if there is any mud, dirt or something inside the airway, they have to just remove the dirt from inside. If there is bleeding going on from some area, they have to just put a tight bandage here so that the bleeding can stop. If suppose the limb is fractured, they have to just immobilize the limb. They have to put a splint here. So this first aid is being given at the disaster site by the paramedical staff, and then they are transporting these injured people to the hospital. In the hospital, you are there, you are in charge of the emergency, and you have got a team of different doctors. And this team of doctors, my dear friends, this team of doctors what you're having, right, in the emergency. Now, each and every member of this team is fully trained. You will assign the duties. Okay, this particular doctor has to take care of the airway. This particular doctor has to take care of the breathing part. This particular doctor may be taking care of the circulation and so on. So you already are prepared in the emergency to receive these injured people. And everyone in your team knows that they have to make sure oxygen delivery to every cell of the body. Now, in this airway, breathing, circulation, if suppose the injured person is having any dirt, mud or any debris in the mouth or any foreign bodies in the mouth, I repeat this in Hindi beta, अगर मान लीजिए जो इंजर्ड लोग आपके पास आ रहे हैं, किसी के मुंह में मान लीजिए मिट्टी भरी है, कचरा भरा है, कोई रोड़े टाइप की चीजें भरी हुई हैं, तो हमें फटाफट से उसके मुंह में से ये सब चीजें निकालनी है जिससे कि ऑक्सीजन अंदर जा सके. As soon as you are able to clear all the debris, the oxygen will be able to go inside, right? If suppose there is any issue, maybe because of injury, there might be swelling of the airway taking place, then you have to put something so that you can deliver oxygen into the trachea. For doing this, we have got different options. For example, you can put the laryngeal mask airway. You can just put a laryngeal mask airway. This what you're seeing beta, this has been asked as an image based question also. You can put the laryngeal mask airway, or maybe you can put the endotracheal tubes. You can use these endotracheal tubes and you can put these endotracheal tubes into the airway. These endotracheal tubes can be put either from the mouth or from the nose. Just a small thing here beta. If by chance you are putting this endotracheal tube through the nose, please ensure that there is no fracture in this particular area. This is the part of anterior cranial fossa. This is the weakest part in the anterior cranial fossa, that is the cribriform plate. If there is a fracture of the cribriform plate and you are putting a tube through the nose, you can understand that there is a risk that you can put this tube into the brain. So nasal intubation should not be done if there is any evidence of fracture of the anterior cranial fossa, right? There are other methods also. Suppose you are not able to put a tube or a mask, laryngeal mask airway from the mouth or from the nose, and you know that patient is not able to take oxygen and we cannot put anything from this area. Patient is not able to take oxygen inside. Patient will die very soon. And you are the doctor, you have to save the life of your patient. So what you can do in this situation, you can just make a cut in the trachea and put a tube into the trachea. That is a tracheostomy. Or if you are not able to access the trachea, you can make a cut in the cricoid cartilage and put a tube in the cricoid cartilage. Or if suppose the patient is dying within seconds, you do not have that much of time to make a cut in the trachea or maybe in the cricoid. You can just pick up the widest bore needle available in the emergency and you can just put a needle into the cricoid cartilage. That is called as needle cricothyroidotomy. So my dear lovely doctors, you have got 5 things to ensure that oxygen can go into the lungs. Either you can use the laryngeal mask airway or the endotracheal tubes or a tracheostomy or a cricothyroidotomy or a needle cricothyroidotomy. I repeat this in Hindi beta. अगर मान लीजिए यहां कोई चोट लगी हुई है और हम देख रहे हैं कि पेशेंट यहां से ऑक्सीजन नहीं ले पा रहा है, उसको सांस नहीं आ रही है, तो बेटा आप दूसरे भगवान हैं। आपको ये ऑक्सीजन उस पेशेंट की लंग्स तक पहुंचाना ही पहुंचाना है। उसको पहुंचाने के लिए आपके पास 5 हथियार हैं। या तो आप लैरिंग्स में एक लैरिंजियल मास्क एयरवे डाल सकते हैं, या मुंह से नाक से एंडोट्रेकियल ट्यूब डाल सकते हैं, या अगर इतना वक्त नहीं है कि हम ये ट्यूबें डालें तो हम ट्रेकिया में एक कट लगा सकते हैं या क्रिकॉइड में एक कट लगा सकते हैं। अगर इतना भी वक्त नहीं है पेशेंट के पास कि हम चाकू से ट्रेकिया में कट लगा पाए, तो जो इमरजेंसी में सबसे मोटी नीडल अवेलेबल है वो नीडल उठा के उसके क्रिकॉइड में डाल देना, जिससे कि कुछ तो ऑक्सीजन उसको चली जाए। If you are able to deliver some oxygen and suppose the lungs are moving, then you will be able to save the life of your patient बेटा। और अगर आप जिंदगी बचा पाओगे तो नेशनल बोर्ड भी आपको पास होने से रोक नहीं पाएगा। If you are able to save the life, then even the National Board of Examination will not be able to stop you from cracking the 17th of December. That is why the National Board of Examiners, they try to create questions wherein they want to ensure that if they give you the license to practice, will you be able to save the life or not? That is why we do get questions from this trauma section quite often. ठीक है बेटा? Now suppose you are able to deliver oxygen into the airway, then you have to ensure whether these air balloons, whether these lungs, ये जो हवा के गुब्बारे हैं, ये are they expanding or not? ये फूल रहे हैं कि नहीं फूल रहे हैं? Many a times, beta, what happens in trauma situations, especially if we try to understand what is actually going to happen. In trauma situations, suppose I say that this is the right lung, this is the left lung. We all understand beta, there is a pleura around these lungs. Just try to understand beta, in trauma patients what can happen. There might be injury to the ribs, there might be injury to the lungs. If the rib is fractured, then the fractured rib will cause injury to the pleura and to the lungs. The air can leak. The fractured rib can cause injury to the vessel, can cause bleeding, and blood can get collected in the pleural cavity. If air gets collected in the pleural cavity, we call it as pneumothorax. If blood gets collected in the pleural cavity, what do we call this? Yes, beta, everybody speak out from your vocal cords. Perfect. Hemothorax. अब ध्यान से देखना बेटा, कितना प्यारा सा कॉन्सेप्ट है. Just try to see a simple concept here. If suppose there is collection of air, अगर यहाँ पे हवा भरना शुरू हो गई, और suppose I say there is hemothorax, suppose there is collection of blood in this area beta, can you see what is happening to the lungs? The lung is getting collapsed. Okay? Because of the pressure by air or blood. And if the lung is getting collapsed, even if you have secured the airway beta, if the lung is not able to expand, then the oxygen will not be going properly into this lung and patient will have difficulty in breathing. There are rare situations also beta, wherein there is such type of trauma where massive air is getting collected in the pleural cavity, and this can cause complete lung collapse on this side plus it may be putting the pressure, because of which the mediastinal structures, that is trachea and everything, will get deviated to the opposite side, and then this air is going to put pressure on the opposite lung as well. If there is pressure on the opposite lung as well, you can very well understand now what is going to happen, beta. There is hardly anything where oxygen can go inside. This would be a dire emergency type of situation. This patient is going to die within seconds. इसको सांस नहीं आ रही है, ऐसा लग रहा है किसी ने इसके मुंह पे कपड़ा बांध दिया है, नाक पे कपड़ा बांध दिया है. Just try to imagine, this is a situation where somebody has put a cloth on the mouth and the nose so that the patient is not able to take any oxygen inside, and this patient is going to die very soon. Always remember, beta, you are the second God. You have to save the life of this patient. If you can do something very quickly by which you can remove this air, if it is a tension, if it is an emergency type of situation, beta, you can simply put a needle and try to remove the air. If it is not an emergency, suppose I say it is a case something like this, where the opposite lung is not pressed, where it is not an emergency, but only one lung is getting collapsed, you want that this lung should also expand. Herein you have got sufficient time, because air is going, oxygen is going into this lung, and it would be going into the blood. This patient is not going to die immediately. But yes, this lung should be expanded, so you have got sufficient time, and you can put a tube into the pleural cavity and try to drain this collection with a tube. Okay? As soon as you drain this collection, beta, जैसे ये collection बाहर निकल जाएगा, फिर क्या होगा? All this hematoma will be drained, and then you ask the patient, suppose the lung was like this, and now the hematoma or the pneumothorax has been drained. Now you ask the patient to breathe in, breathing exercises. उसके lungs को expand करना है, उसके गुब्बारे को फुलाना है. So if the patient starts breathing exercises nicely, then this lung will start expanding nicely. And if you are able to expand the patient's lung, you can imagine, beta, you are able to deliver the oxygen nicely everywhere in the lungs, right? Now, once the breathing part has been taken care of, once you are able to ensure that oxygen is nicely going into the lungs and the lungs are expanded nicely, then from the lung, from the alveoli, this oxygen will go into the circulation. Now herein, beta, we all can understand God has given us the blood vessels. So this oxygen has now started going into the blood. And through blood, this oxygen will be traveling to different parts of the body. Here also, we have to ensure that many times what we commonly see in injured patients, beta, that there is injury here and there, maybe injury to the bones, maybe a femur fracture, maybe a tibia, humerus fracture, maybe injury into the thorax where bleeding is going on, maybe injury in the abdomen like liver injury, splenic injury, because of which the blood vessels are ruptured. And if the blood vessels are ruptured, we can very well understand that whatever blood is flowing inside, if there is leak in the blood vessel, then this blood will be leaking out from the injured site. So the blood is going to leak out from the injured site. That means what we have to do, oxygen you are able to deliver into the blood. Oxygen beta आप यहाँ तक पहुँचा चुके हैं. लेकिन if suppose the circulatory volume is not there, if the bleeding is taking place, if RBC is leaking out, if hemoglobin is leaking out, then you have to ensure that sufficient volume is available in this vascular compartment so that whatever oxygen is going here and whatever hemoglobin is present here, at least that oxygen can reach to different cells of the body. We can very well understand that if suppose we are saying that this is the pipeline for, if suppose the circulation is leaking, if bleeding is going on, then the intravascular volume is also going down. Just give me a moment. I'll try to demonstrate this with a simple water bottle here. Just give me a moment. Right, beta. So I just brought this water bottle. Okay. This is just to demonstrate, beta, that suppose I say that okay. Fine. Now suppose this is a water bottle, what you're seeing here, and let us imagine that this is the vascular compartment. This is the vessel inside us which is carrying the oxygen. So instead of water inside this, you just imagine that there is blood inside this. Now suppose I say there is a trauma, injury to any area in the body, beta. What will happen? This injury is going to cause bleeding. So when bleeding occurs, the blood is getting lost. Can you see? The blood is getting lost. Now, there is decreased volume inside this vessel. So the pressure exerted by blood on the wall of this vessel will decrease. That means the blood pressure is going down. And if the pressure inside this vessel is going down, then you can understand the oxygen will not be able to transport because there is less pressure in the system. So how this flow will happen? If the bleeding keeps on going, if the bleeding is going on, the intravascular volume is going down. So now what is happening? Further decrease in blood pressure. As a doctor, we can understand now that if the pressure in the system is going down, even if you are able to deliver oxygen into the blood, but there is no pressure in the system, so how will the oxygen reach to different cells of the body? That means as a doctor, you have to ensure that intravascular volume is restored. You have to fill this vessel. You have to put something inside this vessel so as to generate the pressure so that whatever oxygen is there inside this patient, at least that oxygen can be delivered to different cells of the body. So my dear lovely doctors, what is the role of circulatory management, or what is the concept of circulatory management? Here we can understand nicely that if suppose the intravascular volume is going down, then you will start pumping in fluids into this. And when you are pumping the fluids into this, you will try to increase the pressure in the system. And when you are able to increase the pressure in the system, the oxygen delivery to different cells can occur. Which type of fluid should be given in these situations? There are two types of fluids, beta. One is a crystalloid and another is a colloid. The difference between crystalloid and colloid is something which does not have any proteins. But colloid is something which has got proteins. Proteins are something which can exert osmotic pressure. Now let us just try to focus on this story beta. If you are giving fluids into this compartment, right? Suppose we are giving colloids, and let me draw this colloid with say this purple color. If I am giving the colloid beta in this compartment, colloid is something which has got proteins. So colloid is going here, plus colloid is also going out here. Now the problem is, if colloid gets collected into this area, what is going to happen? This colloid is having the proteins. So if proteins are present here, this protein is going to exert osmotic pressure, and because of the osmotic pressure, this protein will drag more fluid from the intravascular to the extravascular space. I repeat this beta, if you give a colloid solution initially in a trauma patient, any subject, any patient who is bleeding beta, it is not something only surgery. Bleeding is seen in so many areas. Even in obs and gynae, you read about postpartum hemorrhage and all that stuff. So this is a general concept. Whenever the intravascular volume is going down in a bleeding patient and you have to pump in fluids, especially at that point initially where the blood vessel is leaking, if you give colloids, colloids have got proteins, colloid is leaking out and protein is leaking out. If the protein leaks into the extravascular space, it will exert osmotic pressure and it will drag more fluid from the intra to the extravascular space. That is the reason beta, that is the concept why we do not give colloids initially in a bleeding patient. If you give crystalloids, suppose I draw the crystalloids with a brown color. Now suppose I am giving crystalloid solution here. Agreed that crystalloid would be going here. Agreed that crystalloid would be leaking outside in this particular area. But my dear doctors, this crystalloid does not have any proteins. So if there are no proteins here, it will not further drag the intravascular fluid outside. That means whatever leak is going on, yes, that will remain there, but it will not promote further leak from inside the vessel outside. So that is the reason why we are giving crystalloids, 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 crystalloids initially in a bleeding patient, right? And generally we are using normal saline. Normal saline is the crystalloid what is preferred in a patient of hypovolemic shock, any bleeding situation. However, in a burn situation, we use ringer lactate, which is also a crystalloid solution initially till the time the vessels are leaky. So beta, as soon as you have started pumping in IV fluid into this, the pressure has been generated here, so that whatever oxygen was there, at least that oxygen will be transported to different cells of the body. At this time, we do understand that when the intravascular volume is going down, the pressure inside the vessel is going down, oxygen delivery to cells is going down, the heart immediately reacts to this situation and heart starts pumping faster and faster, faster and faster, faster and faster, so that whatever oxygen is present inside, at least that can be delivered to different cells. So we find tachycardia in a bleeding patient, and that is one of the earliest signs of hypovolemia. In this situation, oxygen requirement is more by the major organs in the body like brain, heart, liver, kidney. So oxygen requirement is not much in the skin. So God has created a mechanism where whenever the patient is going into hypovolemia and oxygen is required more by the major organs, the blood vessels which are present in your skin, they constrict. so that the blood can migrate from these skin vessels and the blood can go to major organs in the body. That means tachycardia is the earliest sign. Cutaneous vasoconstriction is also an early sign of hypovolemia. If the bleeding is going on, the RBC is going down, the hemoglobin is going out, there is a possibility that if more than 30% of blood loss has occurred in this patient, then sufficient hemoglobin is also not present. So just by pumping in fluids, since the oxygen hemoglobin association is less, because the hemoglobin content is less, then also we face a challenge that how this oxygen will be delivered to the cells. So more than 30% blood loss has occurred in a patient, we should pump in blood. Ideal replacement of blood loss is blood transfusion. We also understand the importance of different cells in the blood, like RBCs. Yes, we need hemoglobin for oxygen transport. Apart from this, platelets, clotting factors, they are also required, because it is the platelets and clotting factors which will promote the formation of the clot, and that will help in stopping this bleed. We are trying to understand a situation where the patient is losing blood rapidly. Initially, we have started pumping in IV fluids, crystalloids. Normal saline is going inside just to maintain the pressure inside the vessels so that oxygen can be delivered. But if the amount of hemoglobin has dropped down drastically, we are also giving blood transfusion, we are also giving RBCs. At the same time, we do understand that we have to stop this bleed also. And the best method to stop the bleed, beta, if suppose you get hurt somewhere, अगर मान लीजिए आपको कहीं पे चोट लग जाती है और bleeding होती है, तो what you are supposed to do is you just apply the direct pressure, and by applying the pressure, the bleeding can stop. And bleeding stops because the platelets, the clotting factors, they have formed a clot at the site of bleed. In these type of trauma situations also, agreed, we are giving RBCs, hemoglobin, but we also need platelets and clotting factors which will help in sealing the bleeding point. So you are pumping in IV fluids, you are pumping in RBCs, you are pumping in platelets, you are pumping in clotting factors through fresh frozen plasma. And we many a times give injection of a hemostatic agent, tranexamic acid. First dose should be given within 10 minutes. If not given within 10 minutes, then preferably within 3 hours we should give that, and second dose should be repeated within 8 hours. This is how we are trying to control the bleed also. We are trying to restore the intravascular volume and the vascular pressure. Many a times, beta, there are situations wherein even by doing all this, the patient keeps on bleeding, keeps on bleeding, keeps on bleeding. Patient is not getting stabilized even after pumping IV fluids, blood and tranexamic acid. You are the God. You are the second God, beta. You understand that if the bleeding is massive, unless and until you stop this bleeding, the patient will not be saved. That means you have to apply direct pressure at the bleeding site. And if there would have been any external bleed, you would have applied the direct pressure like this. But if there is any internal bleed, maybe inside the thorax, maybe inside the abdomen, maybe from a femur fracture, you have to explore that area. You have to immediately open that area surgically, go to the bleeding site, apply direct pressure at the bleeding point. If you are able to apply direct pressure at the bleeding point, beta, then yes, your job has been done. If you are able to apply direct pressure at the bleeding point, for example, if the patient is bleeding, now what you're doing is you have done the exploration and you have put the direct pressure here. Now, once the direct pressure is there, the bleeding will stop. And now you ask the people around to pump in fluids. Now whatever fluid is being pumped, whatever normal saline or blood is being pumped in this patient, that will remain inside the circulation, that will increase the pressure inside, and that will help in oxygen delivery to different parts of the body. So that is how you save the life, and that is the whole concept of circulatory management. I hope, beta, you have got this concept nicely. A simple, basic common sense that we have to ensure oxygen going to every cell of the body, right? Okay, now let's see what all is written in our workbook. So, beta, this is your page number 9. The first chapter in surgery, that is trauma. The first lesson what we are trying to learn in surgery is how to save the life. जिंदगी कैसे बचानी है. अगर हम जिंदगी बचा सकते हैं किसी की, तो आप सोच सकते हैं कि what you are doing to this society, right? Even National Board of Examiners, they also want to ensure that whether you understand the concept, the knowledge, that how you have to save the life. That is why they keep on creating questions related to this area. So first, beta, we are talking about the disaster management stories, how to save the life in disaster situations. Every country is following the guidelines laid down by WHO, that is World Health Organization. In India also, beta, we have got a National Disaster Management Authority, National Disaster Management Authority, National Disaster Management Authority. Whose head office is at New Delhi. And this has laid down certain guidelines which we all are supposed to follow and which the examiners are asking on 17th of December. According to this, as soon as we receive the information of a disaster, the first thing what we are supposed to do is start. That is simple triage and rapid treatment. This is done by QRTs. Now, what is this QRT? This is a quick response team. This is a quick response team which comprises of paramedical staff. You immediately send this paramedical staff, maybe a nurse, ward boy, and the ambulance driver at the disaster site. They provide first aid, and after giving the first aid, beta, they transfer the patient back to the hospital. In the hospital, you doctors, you can quickly calculate the emergency severity index. Emergency severity index done by the doctors in the hospital in the triage area. And here the most important thing for you is to save the life. Zindagi bachana hai. Once you are able to save the life, you will be able to triage the patients into different categories. That means segregation of patients. ट्राइज का मतलब क्या है बेटा? सेग्रीगेशन ऑफ पेशेंट्स इनटू डिफरेंट कैटेगरीज डिपेंडिंग ऑन द रिक्वायरमेंट, हाउ फास्ट दे नीड इंटरवेंशन. Therein, suppose if the patient requires immediate intervention, then you classify him in red category. if suppose the patient may not require immediate, but yes, he requires an early intervention, then you can give him a yellow category. If the patient does not require any significant intervention, then green category. If the patient has already died, then black category, and so on. And that is written a little later. And also this is something which we read in our preventive and social medicine classes. Okay. So beta, you are the doctor. As soon as you step into the emergency of the hospital, your aim will be to save the life of your patient. Now, how to save the life? Primary assessment, beta. The most important thing what we follow, that is A, B, C, D, E. एक बार बोलेंगे बेटा, A for, बोलना है बेटा, you have to speak out from your vocal cords. हाँ? A for airway, B for breathing, C for circulation, D for disability, and E for exposure. Now, as we know, beta, this was the question which was asked in the recent 4th of June exam. But herein, I would like to remind you, the question was something like, a 2-year-old baby was having loose motions and vomiting. He presented to the emergency where resuscitation was done. And what does D stands for in ABCDE in this resuscitation? And the options were diarrhea, dehydration, disability, and something else. So by looking at the question, many students got confused. He is telling something about a 2-year-old baby who is presenting with loose motions and vomiting. So this should be a case of dehydration, most likely. So the answer should be dehydration. But actually, beta, in the question itself, the examiner specified what does D stands for in A, B, C, D, E. So we can clearly see that in A, B, C, D, E, D stands for disability, right? Okay. Once we are able to save the life, beta, then we do a secondary survey. In secondary survey, this is done after saving the life. We take a detailed history, do a detailed clinical examination from head to toe, carry out all the special investigations, and then do specific treatment for the injury. But first, primary assessment, where we have to save the life, and triage. Once the life is saved, we have got plenty of time for secondary survey, where we take a detailed history, detailed examination, detailed investigations, and the treatment required for that specific injury. In the primary assessment, beta, as we talked about, we focus on airway, then we focus on breathing, then we focus on circulation, and then we talk something about disability, and then we talk something about exposure. So in airway, beta, we know that we have to clear the airway. So for clearing the airway, we have to clear any debris, mud, dirt, any foreign bodies. If there are any fractures, maybe cervical spine fracture, then we have to immobilize those fractures using a cervical collar. Okay. Nasal intubation is contraindicated. This CI, this is contraindicated. Contraindicated means you cannot do this at all. So nasal intubation is contraindicated in anterior cranial fossa fractures. Anterior cranial fossa fracture. ये हैशटैग जो है बेटा, दिस हैशटैग इज यूज्ड फॉर फ्रैक्चर्स. अब इन द एग्जाम ऑन 17th of December, they may mention anterior cranial fossa or they may write cribriform plate. Cribriform plate is the weakest part here. ये जो एरिया होता है ना बेटा, ये नाक का जो टॉप एरिया, दिस टॉप एरिया एट द नोज, राइट? So cribriform plate fractures. To secure this, we have got the option of using laryngeal mask, airway, and endotracheal tubes. We have got the option of tracheostomy, cricothyroidotomy, and needle cricothyroidotomy. Here, In needlecricothyroidotomy, we use the widest bore needle available. Widest bore needle available in the emergency. Widest bore needle available in the emergency. Once we are done with the airway management, then we come to breathing beta. And in breathing, we understand that if suppose there is anybody who is putting pressure on the lungs because of which the lungs are getting collapsed, maybe there is pressure by the air or maybe there is pressure by the blood, then we have to put a tube and drain that collection. Once we drain that collection, then we encourage the patient for breathing exercises so that the lung can expand. So beta, if there is any pleural collection, whether there is pneumothorax or hemothorax, the most important thing is we have to drain the collection. We have to drain the collection. And then breathing exercise just to allow adequate lung expansion. So what we can do in this situation, beta? We can simply drain the collection and advise breathing exercises. What we are trying to achieve here, beta, that lung should expand. Adequate lung expansion. जो हवा के गुब्बारे भगवान ने दिए ना बेटा, उनको अच्छे से फूलना चाहिए, तभी तो ऑक्सीजन नीचे तक जाएगी. Sometimes what happens, beta, in trauma situations, we find that the respiratory muscles are paralyzed. If the muscles are paralyzed, the lungs are, obviously the movements are not there, so we have to put the patient on a breathing machine, artificial lung machine. Okay? So if the respiratory muscles are paralyzed, then what we can do is we can provide ventilatory support. Ventilatory support. Okay? So that is how we can deal with this situation. Right. Now, in the circulatory management, beta, we know if the pipeline which is carrying the blood, जैसे घरों में पानी की पाइपलाइन होती है ना बेटा, तो अगर वो पानी की पाइपलाइन फट जाती है तो पानी घर में नहीं आ पाता है. Just I'm trying to give an example, beta, that if suppose there is a water pipeline which is coming to our houses and we are receiving water, suppose that water pipeline bursts somewhere, then water is leaking out somewhere and the water is not reaching into our house. The same story is what we have to take care in the circulatory management. That if any blood vessel is injured inside the body, obviously the blood is leaking out. So oxygen is not reaching to different cells in the body. Now for this beta, tachycardia is the earliest sign of hypovolemia. Earliest sign of hypovolemia, and cutaneous vasoconstriction. Cutaneous vasoconstriction. This is also a early sign. This is also a early sign of hypovolemia. Hypovolemia. But hypotension, that is fall in systolic blood pressure, is a late sign of hypovolemia, which is seen if there is more than 30% of blood loss. यानी ब्लड प्रेशर का गिरना एकदम से नहीं होता. पहले हार्ट इज ट्राइंग टू कॉम्पेंसेट by pumping faster and faster. But if the patient is continuously losing blood, then yes, the vascular pressure, the systolic pressure in the arteries, that is going down. That is a late sign of hypovolemia. And we all know, beta, we have to restore the vascular compartment. So we have to pump in IV fluids, and the initial fluid of choice for resuscitation is isotonic crystalloid. Isotonic crystalloids. And here in the crystalloids, beta, we use normal saline. NS is normal saline. We can also use ringer lactate. RL is ringer lactate, but generally what we prefer is normal saline. Ringer lactate is preferred in burn patients. Okay. So what we are going to do is we have to give 1 liter. This is 1 liter of normal saline in 1 hour. That is what we call as fluid challenge. That means you have to give huge amount of fluid in a short period of time. So which type of cannula would you use in this patient? Would you use a narrow bore cannula or a wide bore cannula? अगर बेटा बहुत जल्दी जल्दी हमको ज़्यादा पानी चढ़ाना है तो हम पतला कैनुला इस्तेमाल करेंगे या मोटा कैनुला इस्तेमाल करेंगे? Yes, very right. You will use a wide bore cannula. Now, if we take a look at the different cannulas, generally, beta, what we are doing, we are using two wide bore cannulas. Okay, and if we just take a look at the different cannulas, because this is something what is asked in our NEET PG exam. Now here in beta, if you just take a look how to remember the color coding of the cannulas, there is a very simple mnemonic. If you look at the core of the earth, अगर हम धरती के अंदर चले जाएं, धरती के बीचों बीच चले जाएं, we all have seen those volcanic eruptions. When the lava erupts out, it is red, hot, orange type. So let us try to remember the central core of the earth is orange. The surface of the earth, beta, the roads, they are gray in color. And on the surface of the earth, God has given green grass. And in this green grass, the pink flowers, they blossom. And above us is a blue sky. And in that blue sky, there is a yellow sun. And in rainy season, beta, we see a rainbow around that is a violet color. Okay, so let us try to remember these color cannulas, beta. Orange, gray, green, pink, blue, yellow, violet. अब speak out with me, right? मेरे साथ साथ बोलना बेटा आपको. ओके, ऑरेंज, ग्रे, ग्रीन, पिंक, ब्लू, येलो, वॉयलेट. ऑरेंज, ग्रे, ग्रीन, पिंक, ब्लू, येलो, वॉयलेट. एक बार फिर से बोलेंगे बेटा. वंस अगेन, ऑरेंज, ग्रे, ग्रीन, पिंक, ब्लू, येलो, वॉयलेट. वंस अगेन बेटा. ऑरेंज, ग्रे, ग्रीन, पिंक, blue, yellow, violet. Speak out once again, beta. Very good. Once again. Once again, beta. Orange, gray, green, pink, blue, yellow, violet. Once again. Very good. Perfect. Wonderful, beta. That's really good. Great. बस ऐसे ही बेटा ऐसे ही याद करते हुए जाना है. हाँ, एक बार let us just take a look once again at this. See, the central core of the earth is orange. Then the roads are gray. On the surface of the earth, there's a green grass. So green, and in that green grass, the pink flowers, they blossom. Above us, there is a blue sky, and in that, there is a yellow sun. And then in rainy season, in the rainbows, there is a violet color. Okay, so orange, gray, green, pink, blue, yellow, and violet. Now, if we take a look at the size of these cannulas, beta, this orange is 14 Ks. And now you just keep on adding two numbers, 14, 16, 18, 20, 22, 24, and 26. Once again, beta, 14, 16, 18, 20, 22, 24, and 26. This orange color is the wide bore cannula, beta, and then the bore starts going down. So out of the given colors, orange is the widest, then comes the gray, and then comes the green, then the pink. So it is becoming narrower and narrower. That means when you have to pump in more amount of fluid in a short period of time, you prefer using wide bore cannulas like the orange and the gray color. In normal situations, not a trauma, not a shock type of situation, but suppose a patient has come to the hospital, maybe for some surgery, elective surgery or something, then we use the IV access. In case of adult males, we use green. In adult females, we use pink. Pink, we know, beta, that is the color of females, right? In children, we use blue color. In infant, that is less than 1 year, we use yellow color. And a newborn baby who is having very thin veins, we use a violet color, that is 26 Ks, right? So now let's take a look here. This is what is written here, beta. 14 orange, 16 is gray. They are wide bore cannulas. They are commonly used in shock patients. 18 Ks, green. This is normally used in adult males. 20 is pink. That is normally used in adult females. 22 is blue. That is normally used in children. 24 is yellow. That is normally used in infant. 26 is violet, that is normally used in neonate. Now just to remind you, beta, infant is someone who is less than 1 year of age. Less than 1 year of age is infant. And neonate is less than equal to 28 days of birth. जन्म के बाद पहले 28 दिन, that is neonate, right? So what we are trying to do, beta, the bleeding patient, the circulatory volume is going down, so the pressure is going down. We are trying to restore the pressure so that whatever oxygen the patient is having, at least that can be delivered. We are pumping in IV fluids, crystalloids, normal saline through two wide bore IV cannulas, maybe orange color or gray color. And when we are pumping this fluid, if suppose the fluid volume is adequate, that means this fluid is reaching to the kidneys, and the kidneys would also be able to filter this urine out. So what we doctors can do, beta, we can monitor the urine output of these patients. If suppose the urine output is adequate, that means whatever fluid we are giving, that is remaining inside the circulation and is able to reach to the kidneys. Okay, so what we can do is we can simply monitor the urine output. That will give us an idea whether we have to increase the fluid resuscitation or decrease the fluid. Minimal, इसको काट देना बेटा, just cut this normal, this end circle was normal, rather than write it as minimum. Minimum urine output in case of adult should be 0.5 ml per kg per hour. In case of children, it should be 1 ml per kg per hour. In case of infant, it should be 2 ml per kg per hour. We are pumping in fluid, we are monitoring the urine output. Apart from fluid beta, if more than 30% of blood loss has occurred, that means RBCs have gone drastically, hemoglobin has gone drastically. We want hemoglobin to carry the oxygen now. So this is the indication for giving blood transfusion. And not only RBCs beta, we have to give the platelets and the fresh frozen plasma, which is a rich source of clotting factors. Whenever we have to pump in blood and we don't know the blood group of the patient, the safest blood to be given is O negative, because this does not have any antigens. Just we know A, B, and O. A blood group patient will be having A antigen on their RBC. B blood group patients will be having B antigen on their RBCs. AB blood group patient will be having A and B, both the antigen on the RBCs. And O blood group patient will not be having any antigen on their RBCs. Positive and negative is related to RH factor. So RH is also an antigen, right? So if we don't know what is the blood group of the recipient, and since we have to give blood, we prefer using O negative blood, right? To stop the bleed beta, we also give an injection of tranexamic acid. We give an injection of tranexamic acid. Injection of tranexamic acid. First dose should be given within 10 minutes, or we can give within 3 hours, and second dose should be repeated within 8 hours. 8 घंटे के अंदर सेकेंड डोज को रिपीट कर देना बेटा. This will help in controlling the bleed. अच्छा, let me just tell you beta, these terms, like you are seeing, there is a bar over C, and the doctors are also using this, a bar beneath the C. Now what these means beta, just to make a small mention, this is with and this is which. कौन सा वाला विच है बेटा? ये वाला विच है कि ये वाला विच है? ऊपर वाला विच होता है कि नीचे वाला विच होता है? Yes, this is not right. है ना? So this is this, right? Okay beta. So we are trying to control the bleed. We have given the tranexamic acid. If the bleeding is not getting controlled beta and patient is still bleeding, that means this patient is going to die very soon. This is the time when we have to apply direct pressure at the bleeding site so that we can save the life of this patient. If needed, immediate surgical exploration has to be done to control the bleeding. You can just make a mention here beta, best method to control bleeding. Best method to control bleeding is direct pressure. Direct pressure. Best method to control bleeding is direct pressure. Right. So till now what we have done beta, we just talked about ABC, that is how to secure the airway, how to secure the breathing by lung expansion, and how to secure the circulatory compartment by pumping in fluids, blood, tranexamic acid to stop the bleed. If nothing helps, we have to do the exploration, apply the direct pressure and take control of the bleeding, right? Okay. Once we have done this, we are able to save the life of the patient. We can assess the disability. Disability can be assessed by the loss of consciousness levels in the patient. For example, beta, if suppose I say that there is bleeding going on from anywhere in the body, कहीं से भी bleed हो रहा है बेटा, maybe a femur fracture, liver, spleen, chest, pelvic fracture, bleeding is going on. So we can understand that the intravascular volume is going down, the pressure is going down. That means the oxygen supply to the different parts of the body is going down. That means even if it is a case of femur fracture, or it is a case of liver injury, or it is a case of splenic injury, the oxygen is not getting supplied to every part of the body. So the oxygen supply to the brain would be getting hampered. अगर brain को oxygen नहीं मिल रही है, if brain is not receiving the oxygen, then the response of the brain, that will also be going down. The patient may be losing the consciousness. And then when we assess the brain response, we can take the parameters like eye responses, verbal responses, and the motor responses. Those responses will also be going down. And they can be assessed by a very hot topic for your exams, Glasgow Coma Scale. Last 5 exams, you always had this Glasgow Coma Scale at least in one question in your exam. पिछले 5 एग्जाम में लगातार ग्लासगो कोमा स्केल से रिलेटेड कुछ ना कुछ हमेशा आ रहा है. Moral of the story, what I'm trying to tell you, beta, that Glasgow Coma Scale is not something which is only related to head injury. Actually, Glasgow Coma Scale is something which is related to any trauma patient, any patient who is bleeding. Maybe just the patient is having a femur fracture. Then also the blood is getting lost. That means the supply to the brain is getting affected. That is why the brain is showing signs of loss of consciousness, which you as a doctor can assess by looking at the eye response of the patient, verbal response of the patient, and motor response of the patient. Right? So this Glasgow Coma Scale is not used only in head injury. It is used in all trauma patients. Right, beta? I repeat this in Hindi. सिंपल सी बात है बेटा कि अगर मान लीजिए बॉडी में कहीं भी चोट लगी है, चाहे फीमर को चोट लगी हो, लिवर को लगी हो, स्प्लीन को लगी हो, अगर ब्लीडिंग हो रही है बेटा, तो वेसल के अंदर की वॉल्यूम कम हो रही है ना. अगर वेसल के वॉल्यूम कम हो रही है तो वेसल पे प्रेशर भी कम हो रहा है. अगर प्रेशर कम हो रहा है तो ऑक्सीजन नहीं जा पा रही ना बेटा सारे हिस्सों में, ब्रेन को भी ऑक्सीजन नहीं जा पा रही ना. तो अगर ब्रेन को ऑक्सीजन नहीं जा पा रही है तो ब्रेन में कुछ साइंस तो आना शुरू हो जाएंगे, यानी कि पेशेंट को हो सकता है बेहोशी आने लगे. और हम डॉक्टर होने के नाते ब्रेन के रेस्पॉन्स को चेक कर सकते हैं कि पेशेंट अपनी आंखें ठीक से खोल रहा है कि नहीं खोल रहा, पेशेंट ठीक से बातचीत कर रहा है कि नहीं कर रहा है, पेशेंट की मसल्स ठीक से मूव कर रही है कि नहीं कर रही है ना. तो ये अगर कहीं भी ब्लीड होता है और ब्रेन की सप्लाई हैम्पर होती है तो हम इस ग्लासगो कोमा स्केल की मदद ले सकते हैं और हमें एक आइडिया मिल जाता है कि अंदर क्या कहानी चल रही है और हमें किस तरह से और एक्ट करना चाहिए. क्या ये कहानी स्टेबल हो रही है, क्या ये कहानी खराब हो रही है, क्या ये कहानी इम्प्रूव कर रही है. तो ग्लासगो कोमा स्केल कैन एक्ट एज अ गाइड and it can tell us whether whatever resuscitation we are doing, whether that resuscitation is helping the patient or not. Right? Okay. Now, in Glasgow Coma Scale, beta, we measure the 3 responses. These 3 responses, I will come to that eye, verbal and motor responses. But before looking at the Glasgow Coma, just a small mention about a TRIS score which we use in trauma patients. That is a Trauma Injury Severity Score, which comprises of the age of the injured, injury severity score, and the revised trauma score. Why age is important, beta? Because adult person can tolerate the hemodynamic turbulences a little easily as compared to extremes of ages. A small baby, elderly person, if there is bleeding, they may not be able to compensate hemodynamically faster. So we have to be a little more cautious in managing the small babies and the elderly people. Injury severity score beta, that is an anatomical scoring, and revised trauma score is a physiological scoring. Revised trauma score is actually a combination of systolic blood pressure, respiratory rate, and Glasgow Coma Scale, right? Okay. Now, what is important for us, what we do in the clinical practice is we assess this Glasgow Coma Scale nicely. And for that, eye, verbal and motor. We can remember this mnemonic by EVM, Electronic Voting Machine. आपने वोट डाला है बेटा कभी कभी मौका मिला आपको नहीं मिला कोई बात नहीं आप लोग बाहर रहे इतने सालों है ना तो you might not have been able to vote but yes in our country we are using those EVMs electronic voting machines. पॉलिटिक्स में कई बार चलता है ना कि कोई इलेक्शन हार गया somebody has lost the election then the opposition party starts blaming कि they have tampered with the EVMs है ना so we can just remember this EVM. अच्छा बेटा in EVM maximum if we see maximum I is 4 verbal is 5 and motor is 6. Minimum I 1 verbal 1 motor 1. That means total if we see 4 plus 5 plus 6 is 15 and minimum 1 plus 1 plus 1 is 3. That means the Glasgow Coma Scale in total maximum can be 15, minimum can be 3. And based on this, we can classify the severity of injury into mild, moderate and severe. Now here if you take a look, mild is 13 to 15, moderate is 9 to 12 and severe is 8 or less than 8, right? Abhi, just to remember it easily, we can simply remember one value, the middle value. Chalti kya 9 se 12, chalti kya 9 se 12, 9 to 12. 9 to 12 is moderate. Let us just remember this value. So anything above 12, that will be mild. Anything below 9, that will be severe. So moderate is what we remember, that is 9 to 12. And my dear doctors, 4th of June 2022, there was a question. A patient is injured and he is having a Glasgow Coma Scale of 10. What category he belongs to? Mild, moderate, severe. So what was the answer beta? Perfect, moderate. है ना? तो ऐसे भी questions आते हैं. So till now in this 1.5 hour discussion, we saw 2 questions. One was disability, another is moderate. है ना? So this Glasgow Coma Scale especially is going to be very important for us. In a coma patient, the GCS would be 8 or less than 8, and even if the patient has died, then the minimum GCS possible is 3. Okay. Now, how do we assess these responses? For this, let us just try to understand better. You are the doctor in the emergency, right? Now, the patients, there are a lot of patients in front of you. You have to quickly calculate the I score. First, I'll say this in English and then I'll say this in Hindi. Okay. So, to calculate the I score, if suppose the patient has come to you and he looks to be fine, he is able to open his eyes on his own, spontaneously opening the eyes, spontaneous, we give 4 marks. If suppose the patient is drowsy, he is lying like this, then you give him a voice command, open your eyes, and he suddenly opens his eyes. This is a voice command, or maybe even to sound command. Suppose there is suddenly some noise. Maybe something has fallen down, right? Maybe something has fallen like this. So just by the sound, the patient opens his eyes. Right? So this is I3. If the patient does not open his eyes to this voice command, then you give him some painful pressure stimulus, and then he might open his eyes. This is I2. And if the patient does not open his eyes even on pain or pressure stimulus, this is I1. I repeat this in Hindi बेटा. आप जब इमरजेंसी में हैं तो अलग अलग तरह के मरीज आपके सामने हैं. आपको आई रिस्पॉन्स अगर देखना है तो हो सकता है बेटा कोई इंजर्ड होगा जो थोड़ा सा ठीक ठाक होगा, वो अपनी आंखें अपने आप खोल सकता है, और अपने आप अगर वो आंखें खोल रहा है, आपको देख रहा है, तो आप 4 नंबर दे देते हैं. अगर मान लीजिए उसकी आंखें बंद हैं तो आप उसको आवाज देते हैं, आंख खोलिए, एंड देन ही ओपन्स हिज आईज. तो इसको अपन 3 नंबर दे देते हैं. या वॉइस कमांड ही नहीं, कोई और दूसरी आवाज, जैसे मान लो इमरजेंसी में अचानक से कोई ग्लास गिर गया या कोई स्टील की बोतल रखी थी पानी की, वो गिर गई. नाउ ये जो आवाज आई, इससे अगर उसकी आंख खुल गई तो भी अपन उसको 3 नंबर दे देते हैं. अगर मान लो इस आवाज से आंख नहीं खुलती है तो फिर हम उसको दर्द देते हैं या प्रेशर देते हैं, और उससे अगर वो अपनी आंख खोल देता है तो इसको अपन 2 नंबर दे देते हैं. और अगर इतना करने के बाद भी उसकी आंख नहीं खुलती है तो अपन उसे 1 नंबर दे देते हैं. राइट? If he is not able to open his eyes even on painful pressure stimulus, we give 1 score. And in these situations, we should check whether the patient is alive or not. Right? Now, for verbal responses, if suppose the patient is fully conscious and oriented nicely to time, place and person, he is talking to you nicely like a decent person, that see doctor, what happened in that building collapse, there are so many people who got injured, please try to take as much care as possible and try to save as many lives as possible. That means he looks in a sound state of mind. You give him a verbal score of 5. If suppose the injured person is confused, hey, who are you? Why you are here? This is my house. What are you doing in my house? He's confused. He's able to talk, but he's not talking properly. This is confused. Okay? If he starts using inappropriate words, if he starts using abusive language, then you give him a verbal score of 3. If he is not able to speak out any words, but he's just making some sounds, no words, only sound is coming out, you give him a verbal score of 2. And if no sound is coming out, then please check whether the patient is alive or not. So here you give him a verbal score of 1. Okay, I repeat this in Hindi now. वर्बल रिस्पॉन्स को देखने के लिए बेटा, अगर मान लीजिए वो जो इंजर्ड है वो आपसे ठीक से सभ्य लोगों की तरह बातचीत कर रहा है कि देखिए डॉक्टर साहब, वो बिल्डिंग गिरी थी, उसमें बहुत सारे लोगों को चोट लगी है, आप कोशिश करके किसी भी तरह से जितने लोगों को हो सके बचाइएगा. दैट मीन्स, इसका मतलब वो नॉर्मल बात कर रहा है, तो हम उसे वर्बल 5 नंबर दे देते हैं. अगर मान लीजिए वो कंफ्यूज्ड है, तुम कौन हो भैया, मेरे घर में क्या कर रहे हो, यहाँ क्यों आए हो, इस तरह की कुछ बातें कर रहा है, मतलब उसे नहीं पता कि वो कहाँ है, क्या हो रहा है, कंफ्यूज्ड है, तो अपन 4 नंबर दे देते हैं. अगर मान लो वो असभ्य भाषा का इस्तेमाल करना शुरू कर दे, गाली देना शुरू कर दे, तो हम उसको 3 नंबर दे देते हैं. अगर उसके मुंह से कोई शब्द ही नहीं निकल रहे हैं, वो कुछ आवाजें ही निकाल पा रहा है, शब्द नहीं आ रहे, आवाज आ रही है, इसको अपन 2 नंबर दे देते हैं. और अगर आवाज भी नहीं आ रही है तो एक बार देख लेते हैं पेशेंट जिंदा भी है कि नहीं है, तो इसको अपन 1 नंबर दे देते हैं. राइट? नाउ मोटर रिस्पॉन्स. मोटर मतलब मसल्स. मोटर मीन्स मसल रिस्पॉन्स. whether his muscles are working nicely or not. So in this motor response, if suppose you ask him to move his right upper limb and he moves the right upper limb like this, that means he's moving it nicely, right? You give him a motor score of 6. But suppose he is not able to move, he is not able to obey your commands, then you try to pinch him. If you try to pinch him, right? If you are pinching him here, and suppose he is able to localize that you are pinching him here, he is localizing. This is motor 5. If suppose you are giving some pinching pressure and he shows a normal flexion movement, you are pinching him here and he shows a normal flexion movement, that means he is trying to withdraw. That is motor 4. If suppose on pinching like this, he shows a abnormal flexion movement, this is motor 3. If on pinching like this, he shows extension movement, this is motor 2. And if suppose there is no movement at all, then you check whether the system is working or not. Now I repeat this in Hindi beta. जब मोटर रिस्पॉन्स देखते बेटा, तो मोटर का मतलब होता है पेशेंट की मसल एक्टिविटी क्या है, मसल के रिस्पॉन्सेस क्या है. अगर मान लीजिए आप उसको बोलते हैं अपना दाहिना हाथ उठाइए और वो अपना दाहिना हाथ ठीक से उठा लेता है, तो इसका मतलब वो आपकी पूरी बात मान पा रहा है और उसकी मसल पावर सब ठीक ठाक है, तो अपन मोटर 6 नंबर दे देते हैं. अगर मान लीजिए वो आपकी बात नहीं मान रहा है, तो हम उसको पिंच करके देखते हैं, और जैसे ही आपने पिंच किया, अगर वो मान लो अपना हाथ ले जाके वहां पे रख रहा है, मतलब वो ये बता पा रहा है कि ये यहाँ पे ऐसा मत करो, वो लोकलाइज कर पा रहा है, तो इसको अपन मोटर 5 नंबर दे देते हैं. अगर मान लो वो नहीं बता पा रहा है और पिंच करने पे एक नॉर्मल फ्लेक्शन मूवमेंट दिखाई दे रहा है, हमें विड्रॉ कर रहा है, वो आप पिंच कर रहे हो और वो विड्रॉ करने की कोशिश कर रहा है, तो मोटर 4 नंबर. अगर मान लो ऐसा पिंच करने पे वो एबनॉर्मल फ्लेक्शन शो कर रहा है, एबनॉर्मल फ्लेक्शन, तो अपन मोटर 3 नंबर दे देते हैं. और मान लो पिंच करने पे अगर वो फ्लेक्शन नहीं एक्सटेंशन शो कर रहा है, तो इसको अपन 2 नंबर दे देते हैं. और अगर पिंच करने पे कोई मूवमेंट ही नहीं हो रहा है, तो फिर देख लेते हैं कि भैया जिंदा भी है कि नहीं है. So this is how we can assess the eye, verbal and motor responses, and based on this we can calculate the GCS. Whenever there is any variation in the response in two sides, suppose on one side there is motor 6 response, on the other side there is a motor 5 response, then on this side it is 6, on this side it is 5. So we choose the best response. Best response is considered. Sometimes, beta, we are not able to test these responses. For example, during injury, if suppose there is huge injury around the eyes and there is lot of edema around the eyes, because of which the patient is not able to open the eyes. Now we are not able to test the eye response. We cannot comment about this eye response. So we use the term NT, non-testable. I, non-testable. ENT, I, non-testable. Sometimes what happens, beta, a patient came to us in a serious condition and we have put the endotracheal tube. Now when you put the endotracheal tube, it is going into the trachea, so it is going through the vocal cords. So now the patient is not going to speak. Patient cannot speak क्योंकि voice box में गई tube, so patient is not able to speak. So we will not be able to test the verbal response, and we write it as VNT, verbal non-testable. ठीक है बेटा? Okay. For calculating the prognosis, कि what will be his future life, आगे की जिंदगी कैसी होगी, the best is motor response. Okay. So these are some important relevant points about Glasgow Coma Scale. Let us just quickly see what all is written here, and then we learn this Glasgow Coma Scale nicely, right? Okay. To calculate the I response beta, if he's able to open the eyes spontaneously, then it is I4. If he opens his eyes to voice command, that is I3. Voice, or you can just write it as sound also. Voice or sound, that is I3. Pressure or pain, that is I2. And no response is I1. If he is conscious and oriented to time, place and person, then it is verbal 5. Confused 4. Inappropriate words 3. Incomprehensible sounds 2. And no sound at all is 1. Motor response, if he is obeying all the commands, it is motor 6. If he is able to localize, motor 5. Normal flexion, or the MCQ people are writing it as withdraws. Normal flexion or withdraws, that is motor 4. Abnormal flexion is motor 3. Extension is motor 2. And no response is motor 1. If we are not able to test any response, we use the term NT. Most useful for prognosis in GCS is the motor response. If variable response in two sides, then best response is considered. If variable response in two sides, then best response is considered. Now beta, we'll just try to revise this nicely, learn this nicely, okay? Right. So I4, you have to speak out from your vocal cords beta. I'll do once for you and then you have to speak out continuously, okay? I4, spontaneous. 3, to voice. 2, pressure. 1, none. Verbal 5, conscious, oriented. Verbal 4, confused. 3, words. 2, sound. 1, none. Motor 6, obeys. 5, localize. 4, normal flexion or withdraws. 3, abnormal flexion. 2, extension. 1, none. Let's do it once again, beta. I4, spontaneous. 3, voice. 2, pressure. 1, none. Verbal 5, oriented. 4, confused. 3, words. 2, sound. 1, none. Motor 6, obeys. 5, localize. 4, withdraws normal flexion. 3, abnormal flexion. 2, extension. 1, none. Once again, beta. I4, spontaneous. 3, voice. 2, pressure. 1, none. Verbal 5, oriented. 4, confused. 3, words. 2, sound. 1, none. Motor 6, obeys. 5, localize. 4, normal flexion withdraws. 3, abnormal flexion. 2, extension. 1, none. Once again, beta. I4, spontaneous. 3, voice. 2, pressure. 1, none. Verbal 5, oriented. 4, confused. 3, words. 2, sound. 1, none. Motor 6, obeys. 5, localize. 4, normal flexion withdraws. 3, abnormal flexion. 2, extension. 1, none. Now let us just remove this and try to learn it. Yes, beta. I4, spontaneous. 3, voice. 2, pressure. 1, none. Verbal 5, oriented. 4, confused. 3, words. 2, sound. 1, none. Motor 6, obeys. 5 localize, 4 normal flexion withdraws, 3 abnormal flexion, 2 extension, 1 none. Now beta, you have to speak out, right? I4, 3, 2, 1, verbal 5, 4, 3, 2, 1. Very good. Motor 6, 5, 4, 3, 2, 1. Very good, beta. Wonderful. Very good. Please keep on speaking out from your vocal cords, right? Let's do it once again, beta. एक बार फिर करेंगे अपन, हाँ? I4, 3, 2, 1. Verbal 5, 4, 3, 2, 1. Motor 6, 5, 4, 3, 2, 1. Wonderful beta. Once again. Very good. एक बार फिर करेंगे बेटा. Let's do it once again. I4, 3, 2, 1. Verbal 5, 4, 3, 2, 1. Motor 6, 5, 4, 3, 2, 1. Perfect beta. That's really great. Spontaneous. I4 spontaneous, 3 to voice, 2 pressure, 1 none. Verbal 5 oriented, 4 confused, 3 words, 2 sound, 1 none. Motor 6 obeys, 5 localize, 4 normal flexion withdraws, 3 abnormal flexion, 2 extension, 1 none. राइट बेटा, बहुत बढ़िया बेटा. बस ऐसे ही हिम्मत से लगे रहना बेटा और अच्छे से बिल्कुल इसको अच्छे से रिवाइज करना बेटा. दिस ग्लासगो स्केल इज रियली गोइंग टू बी वेरी वेरी क्रूशियल फॉर 17th of December. Though each and every word written in the workbook is actually very crucial, but this Glasgow scale, we do expect a question from this particular area. Abhi, last thing in the primary assessment, what we can see beta, in disability, we have assessed the Glasgow scale, right? Okay. Now, by this, we can come to know the gravity of injury, the mild, moderate and severe. Beta, quickly tell me what is moderate? What is moderate? चलती क्या 9 से 12, 9 to 12. Moderate, 9 to 12. Moderate, moderate, moderate. So mild will be and severe will be right. And the last thing what is important in the primary assessment in saving the life beta is exposure of the patient. That means we have to undress the patient completely. We are doctors beta, we should not feel shy about it. We should undress the patient completely, but we should take care of hypothermia. Here I would like to tell you that if the patient is bleeding, blood is getting lost from his body beta, blood is hot, 37-degree temperature. It is not only the blood, the RBC which is getting lost, but it is also the heat which is getting lost from his body. So any trauma patient who is bleeding, he is actually going into hypothermia. So whenever you are undressing the patient, please do take care that you cover him with some blankets or something, because he is already going into hypothermia. Right? If you just expose this patient to air conditioner, the patient will die of hypothermia. That is the reason beta, in these trauma situations or in any bleeding patient, the IV fluids which you are giving, they should not be cold. We warm those fluids and warm solutions should be given. So if we try to summarize beta, A, B, C, D, E, A for, B for, C for, D for, E for. Very good, very good, well done. Now beta, airway mein, I hope we all understand how we can secure the airway. Breathing, we can understand that our aim is lung expansion. And C, circulation, we know that how important it is to transport oxygen in the blood to different cells of the body. So we are giving IV fluids, crystalloids, we are giving blood products, we are giving tranexamic acid to stop the bleed. If nothing is helping, we have to apply direct pressure, and for that we can do a surgical exploration, right? Okay. Then we disability assessment by Glasgow Coma Scale, and we should not forget about exposure. Undress the patient completely, right? And avoid hypothermia. Acha beta, once we are able to save the life of the patient, we can segregate the patients into these different categories: red, yellow, green and black. Red is given to that patient beta who require immediate intervention. Immediate intervention is required. Immediate intervention. That means within 6 hours. And yellow is given to a patient beta where early intervention is required within 6 to 24 hours. Within 6 to 24 hours. And green is an ambulatory patient who may require some hospital care, maybe some suturing or something, but he can easily wait. He does not have any significant injuries. And black is black, that is pulseless. Either the patient has died or the condition is such that whatever best you do, you will not be able to save the life of this patient. So please do not waste your precious seconds or minutes in these black category patients. These are the standard according to the guidelines. There is another category which is white. This is an ambulatory patient who does not require any hospital care also. Does not require any hospital care. Many times when there is a building collapse type of thing, the injured people are being transported to hospital. There would be people nearby also who are watching all this, and they may also come to the hospital along with those injured people. And when they are seeing that you are a great doctor and you are taking such nice care of these injured people, they might come to you and they may ask you, doctor, please check me also whether I am having any injury or not. So you just tell them to please wait and let you work towards the red and yellow category patients, right? Once this primary assessment is done, once the life has been saved, that means God has been really great, that the responsibility which has been given to you, God has helped you in carrying out that responsibility nicely. The life has been saved. Then you can go for detailed survey. That is a secondary survey where we take a detailed history. We do a detailed examination. We do all the special investigations and we can do the definitive treatment. When we are taking the detailed history, we should not forget to ask about these 5 things. Ample. A for allergies, M for medications, P for past illness pregnancy, L for last meal, and E for events of injury. Like medications is really important. If the patient is already taking some medicine, especially those medicines which can cause bleeding tendencies, maybe aspirin, maybe anticoagulants like warfarin or heparin, then we have to immediately stop these medicines because they will increase the risk of bleeding. So stop these medicines and give some counter drugs to counter these medicines. So you can just make a note beta that if patient is already taking aspirin earlier, aspirin is something which is antiplatelet, which causes thinning of the blood. So if the patient is already taking aspirin, you can give platelets. If the patient is taking warfarin, then you can give vitamin K injection, or you can give fresh frozen plasma. Fresh frozen plasma is rich in clotting factors. or you can give heparin. Sorry, if the patient is already taking heparin, then you can give protamine sulfate. Protamine sulfate is the counter drug for heparin. Okay. Pregnancy, yes, it is important to know whether the patient is pregnant or not, because there are two lives who are at risk. If we are doing any special investigations like x-rays or CT scans, then we have to be careful about it. Last meal is important to know, because whatever we eat, जो भी अपन खाते हैं ना बिट्टा, that remains inside the stomach for 3 to 4 hours. So many a times the injured person has come, and suppose he had taken a meal half an hour back, 1 hour back, then the food would be inside the stomach, the intragastric pressure would be high, and the chances of regurgitation and aspiration into the lungs would be high. So what we can do is we can put the nasogastric tube into the stomach and empty the gastric contents, so that the risk of aspiration is not there. Or suppose if you're planning some surgery in this particular patient, immediately you have to take this patient in the operation theater for exploration and control of bleed. Then also it is important that if the patient has taken the food recently, maybe in the last 2 hours, 3 hours, then you put a nasogastric tube and empty the stomach. Right. And events of injury, the sequence of events, how the injury has happened is also important for us to know about. Right. So this is how we actually manage the disaster situation. As soon as we receive the information of disaster, we have sent the quick response teams at the disaster site. Then the paramedical staff have transferred those patients to us after giving the first aid. You are there in the triage area where you have got a team of doctors. You have to deliver oxygen to every cell of the body. You secure the airway, breathing, circulation, assess the loss of consciousness, assess the disability status, and expose the patient completely, taking care of hypothermia. Based on this, you will be able to save the life of the patient. You will be able to do a triage, that is segregate the patients into different categories: red, yellow, green, black, and maybe white. Once all this is done, then you will do a secondary survey where you will take a detailed history, examination, investigations, and specific treatment. In the history, we do not forget to ask about AMPL, A for allergy, M for medication, P for past illness, pregnancy, L for last meal, and E for events of injury. So that is how you manage the disasters, and you are able to save as many lives as possible. Now here, beta, thank you very much for your patience. Thank you for listening so patiently. Thank you for repeating the things from your vocal cords. Just maintain this. Let's take a break here, and let's take a little longer break of maybe 20 minutes today, and let us be back at 12:45 p.m. Let us be back at 12:45 p.m. Thank you very much. God bless you. Right, beta. So we are back, and I hope you are able to understand the primary assessment and the secondary survey. Few queries which I received on WhatsApp. There was a query from Pranshal. He wanted that if there is variable response in two sites, then best response is considered. Please explain in Hindi if possible. Pranshal, अगर मान लीजिए जब आप असेसमेंट कर रहे हैं और सपोज करिए आपको दो तरफ में कोई वेरिएशन मिलता है, अलग अलग मिलता है, जैसे मान लीजिए आपने बोला सीधा हाथ उठाइए तो सीधा हाथ उठा लिया, अब आपने बोला कि बायां हाथ उठाइए तो बायां हाथ वो नहीं उठा पा रहा है ना। इसका मतलब अगर इस तरफ मोटर 6 है तो इस तरफ मोटर 6 नहीं हो रहा है लेफ्ट साइड में, है ना। तो इसका मतलब दोनों तरफ में कुछ वेरिएशन आ रहा है। तो ऐसे में जो बेस्ट रिस्पॉन्स होता है उसको हम ग्लासगो कोमा स्केल में मान लेते हैं। तो आई होप प्रांशल दिस इज डन। Fluid challenge, 1 liter of normal saline within 1 hour. Beta, please always write your name and university. Whenever you are asking any query na beta, now on my WhatsApp, please do mention your name and your university so that I can save in my contacts, and it would be good that if I respond to you with your name so that it gives a little more emotional connect, right? So please do mention your name and university beta. Fluid challenges, we are just pumping in 1 liter of normal saline within quick time, that is 1 hour. After giving crystalloids, Tarun, hypovolemia and tachycardia does not occur. After giving crystalloids, we are treating hypovolemia and we are also trying to reduce the heart rate after giving fluid. It is before giving fluids, if somebody is losing blood, if the intravascular volume is going down, then the tachycardia is happening, heart rate is increasing just to try to push oxygen as much as possible into different cells. But after giving fluids, the heart rate is trying to come down, the blood pressure is trying to increase. Right, so now I'll be taking up whatever queries I think after today's session, we'll take up the queries, right? Okay, so now let's move to the other topic, that is head trauma. Okay. Abhi, what we did in the first session, we tried to save the life. And I request all of you, beta, that please try to follow the concepts, what we have understood in all the 19 subjects. Whenever any patient is bleeding, whether the patient belongs to surgery or to gynae or to orthopedics or any story, if the patient is bleeding, if the patient is going into hypovolemia, you know the protocol, how you have to deliver oxygen to different cells of the body. Now, once we are able to save the life, beta, then let us take a look at the different parts of the body which can get injured. So first we are going to talk about the head trauma story. We are going down in a sequence. First we talk about the head, then we talk about the face, then we talk about the neck, then we talk about the chest, then the abdomen. The limbs, they are nicely discussed in orthopedics, because in orthopedics, again, trauma is another chapter wherein the orthopedic faculty would be discussing with the different type of fractures and things, right? Okay, so now Let us try to take a look about the head trauma. What is there inside the head? What all injuries are classified under head trauma? So this is what is there inside the head, right? If you carefully take a look, beta, inside the head, you can see there is a scalp, and beneath the scalp, there is bone, and beneath the bone, there is brain. So injury to any of these three, whether scalp, bone, or brain, will be classified under head injury. Now, if we go in a sequence here, in the scalp, beta, the different layers of the scalp in anatomy, we know S for skin, C for subcutaneous tissue, A for aponeurosis or galea aponeurotica, L for loose areolar tissue, and P is the periosteum or the pericranium. These are the 5 layers which God has given you in your scalp. Out of these 5 layers, beta, the most dangerous zone for infection is loose areolar tissue. That means there are emissary veins, there are connecting veins from the scalp which are going towards the brain. So we have to just imagine that loose areolar tissue in the scalp is having the veins which are actually going into the brain. As a doctor, how it is important for us? February 23, when you will be practicing in the hospitals, beta, the Friday nights, the Saturday nights, you will be receiving a lot of patients of trauma. And if suppose there is a scalp injury patient, wherein there is injury only to the scalp, but no injury to the bone, no injury to the brain. If the injury in the scalp has gone up to the loose areolar tissue, then the roadside dirt, mud, or something would have gone into the loose areolar tissue. And since there are veins in the loose areolar tissue which are connecting to the brain, this roadside dirt from the scalp can go into the brain and can lead to infections in the brain. That is why loose areolar tissue is considered as the most dangerous zone for infections. And as a doctor, whenever you are coming across these scalp injuries, you should not take them lightly, because these scalp injuries can also cause brain infections. So we should always clean these scalp wounds nicely, irrigate them nicely with normal saline, and suture these scalp wounds in 2 layers. First, we have to put the sutures on the aponeurosis, that is galea, and second, we have to suture the skin, right? Okay, fine. Now, if we move from the scalp to the bone, in the bone, that is skull bone, there can be different type of fractures. For example, there can be a fracture something like this. Here in what you're seeing, beta, in the skull bone, this fracture, what you're seeing here, this is a linear cut in the bone. This is a linear cut in the bone. This is called as a linear fracture. This is generally seen in blunt traumas to the skull. Blunt trauma to the skull. That means if suppose you take your skull and you just put it on the ground, right? This is a blunt trauma. And many a times you will come across that there's a linear cut in the bone which is seen like this. Penetrating traumas, that means injury by sharp objects, can lead to depression in the bone. This is what we call as depressed fracture. You can see some part of the bone is depressed inside. So this is a depressed skull fracture. This image, what you're seeing here, this also you can appreciate there is a depression of the bone. So this is a depressed fracture. This is the clinical presentation of a depressed fracture. Can you see how some part of the bone has actually gone inside? Okay. This is commonly associated with penetrating traumas. Penetrating traumas. That means the sharp traumas, sharp object. For example, suppose we consider that this the outline what you're seeing beta, let us just imagine that this is some wall. This is the flat surface. This is the flat surface of the wall. समझ लेते हैं बेटा, ये जो हम देख रहे हैं ना, ये एक दीवार है ना. ये फोटो हटा देते हैं यहाँ से. ये सिर्फ ये समझते हैं कि ये एक दीवार है. Now this flat surface, if there is injury to the flat surface, injury from the flat surface, this is blunt trauma. But the corner what you are seeing बेटा, ये corners दिखाई दे रहे, ये edges दिखाई दे रही है इसकी. These corners or these edges what you are seeing, this is a sharp edge. So if there is any trauma because of some sharp object, that is what we call as penetrating injuries. Okay, suppose somebody is hitting a knife, so that is a sharp object, and penetrating traumas to the skull leads to depressed fracture. Then beta, there is another type of fracture which we call as base of skull fracture. Base of skull is base of skull. Now if you just take the skull bone in your hand and lift it above your head, if you just take the skull bone in your hand and suppose you remove this mandible from here, you take the skull bone, lift it above, whatever you are seeing in the skull from below, that is what we call as the base of skull. And this base of skull can be divided into anterior cranial fossa, the anterior part, the middle cranial fossa, and the posterior cranial fossa. If there is injury to the anterior cranial fossa, then this particular area, that is the cribriform plate, this is the weakest area and that gets injured. So the CSF from the brain will start coming out from the nose, which we call as CSF rhinorrhea. Many a times in these anterior cranial fossa fractures, there is collection of blood around the eyes, and that is what we call as the raccoon eyes or the panda sign or the periorbital hematomas. If there is injury to the middle cranial fossa, then it is the petrous part of the temporal bone which gets injured most commonly, and CSF starts coming out from the ear, what we call as CSF otorrhea. And many a times we find a bruising or brownish discoloration behind the ear, which we call as the Bettel sign. If there is injury to the posterior cranial fossa, it is the occipital bone which is suffering from injury most commonly, and we may find some bruising or brownish discoloration at the occipital region. Okay, so till now we talked about a linear fracture, we talked about a depressed fracture, something like this. We talked about the base of skull fractures. Base of skull, we divided the base of the skull into three parts: the anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. Apart from this base of skull fracture, we may find some fractures in small babies, which we call as Pons fracture. Many times you would have seen beta that when a small baby fall on the ground, he suffers from injury here. There is a swelling which you see in the scalp region, and many a times we find there is a fracture beneath that scalp swelling. So when you press that swelling, the blood is pushed down, so there is a dent on the swelling. When you remove the pressure, when you release your finger, the swelling comes back again. This is just like a dent in the ping pong ball, and that is called as a Pons fracture. And fifth fracture in the skull is the orbital blowout fracture. Now in the orbital fractures, which are more often discussed in ophthalmology classes, in the orbital fractures, the weakest area is the floor of the orbit or the inferior wall of the orbit, which is most often injured. This was a question on 4th of June 2022. The second weakest part is the medial wall of orbit. So in total beta, in bones, we talked about 5 fractures: linear, depressed, base of skull, Pons, and orbital blowout, right? Now let's just take a look what all is written in the scalp and bone, and then we will see the brain injuries. So as we know that in the head we have got scalp, bone and the brain. Cerebrospinal fluid and skull, they protect our brain. If we focus on the scalp area, most dangerous zone in the scalp is the loose areolar tissue. And the reason is emissary veins. Emissary means messenger. That means these are connecting veins. They are connecting something to someone. So emissary veins are there which are connecting the scalp to the brain. That is why simple scalp injuries can even lead to brain infections. We should not take these scalp lacerations nicely. This is the laceration. All these scalp wounds should be cleaned, irrigated with normal saline. This is normal saline. साफ सफाई करनी है जख्म की अच्छे से. And then these are sutured in 2 layers. First the galea and second the skin. Sometimes scalp laceration can bleed profusely and can cause shock in small babies, shock in infants. Then we talked something related to bone, and in the bone we talked about fractures. Now in these fractures, there can be a linear fracture, there can be a depressed fracture, then there can be a base of skull fracture, then there can be a Pons fracture, and there can be a orbital blowout fracture. Out of these different fractures, beta, linear fracture is something which is caused by blunt trauma. Linear is by blunt trauma, and depressed is something which is caused by penetrating trauma. This can be asked as a image-based question in your exam, beta, and you are supposed to identify that how this depression is seen. पहचान लोगे बेटा इसको. I hope you will be able to identify this depression. Will you be able to identify this depression, beta? Yes? Wonderful. Now in the base of skull, beta, we have divided the base of skull into anterior, middle and posterior cranial fossa. If we focus on the anterior cranial fossa fractures, most common part injured is the cribriform plate. कौन सा part injured होता है बेटा? What is the commonest part injured? Yes, speak out from your vocal cords always, right? So that you keep yourself engaged all the time. Most common part injured is the cribriform plate. This is a part of the ethmoid bone. Abhi, if you take a look at this image, beta, in this particular image, try to see what is happening. There is injury to the cribriform plate here. So what is happening? The CSF from the brain is coming. The CSF is coming out from the nose, and this is called as CSF rhinorrhea. And many a times you see blood collection around the eyes. This is a periorbital hematoma. This is something what we can correlate, or we can relate with the animals like raccoon, who is an Australian animal, or panda, who is found at low temperatures, right? So that panda, the complete panda is white, but there is a blackening around the eyes. So we can call this as a panda sign or raccoon eyes. So how these anterior cranial fossa presents? क्या लिखेंगे बेटा यहाँ पे? What we are going to write here? CSF rhinorrhea. CSF rhinorrhea. And these periorbital hematomas, they are called as raccoon eyes, or we can also call them as panda's sign. Panda's sign. Then there is a middle cranial fossa fracture. In middle cranial fossa, most common part injured is petrous part of temporal bone. Petrous part of temporal bone. And because of this, there can be CSF autoria. We find a brownish blackish discoloration behind the ear in these cases. Now in this particular image what you're seeing beta, herein, can you appreciate there is some bruising what you're seeing here behind the ear. Now this bruising behind the ear is what we call as the Bettel sign. Seen in middle cranial fossa fractures, there would be something here. Maybe you can say some brownish discoloration behind the ear. Okay, you can have a look at this image once again beta. There was a image on 12th of December 2021. There was an image on 12th of December 2021, and they simply asked that this is seen in which condition, right? So actually speaking beta, 12 December 2021, there were two questions. One was related to this raccoon eyes, another was related to this Bettel sign. So I hope you will be able to identify these if by chance they are repeated on 17th of December. Okay. So bruising, brownish discoloration around the mastoid, this is what we call as the Bettel sign. Bettel sign. Right. Then another type of fracture which we see in children. This is the Pons fracture, which is just like a dent in the ping pong ball. Orbital blowout fracture, which we'll be reading in our ophthalmology classes as well. Most common part injured is the inferior wall or the floor of orbit. Inferior wall or the floor of orbit. This was a question on 4th of June 2022. And second most common is the medial wall of orbit. Right, so this is something related to bone injuries in the head. Now we come down to the brain. So what we have talked till now, we have talked about the scapula, we have talked about the bone, and now let's move down into the brain. A brain injury scale, there can be either a coup injury or counter coup injury. Coup is something which is injury at the site of impact, and counter coup is removed from the site of impact. Suppose somebody gives a blow on the forehead. Now this part of the brain which is close to the site of impact, if there is injury to this part of the brain, this will be called as coup. Sometimes what happens beta, when there is a injury here, the brain will shake inside the skull, and because of this shaking of the brain, there may be injury in the brain in the occipital part of the posterior part. So the impact is here, but injury is here. This is injury remote from the site of impact. So this is what we call as counter coup. Counter coup bolte beta isko, okay? And these counter coup injuries are commonly seen when the head is in motion. Head is in motion means if suppose the head is moving and it hits a stationary object. For example, Saturday night, rainy weather, somebody was driving a car at a very high speed and he was drunk, and suddenly he bangs the car in a tree. So if you look at this, the car was moving, the person was moving along with the car, but the tree was not moving, tree was stationary. So this moving head hits a stationary object. In these situations, commonly we find these counter coup injuries as well. Brain injuries can be segregated into primary and secondary. Primary is a direct injury to the brain parenchyma, and secondary is actually the after effect of primary brain injuries. For example, if we take a look at one of the images here. Now, in this particular picture, if we try to understand this primary and secondary beta, just have a look at the screen carefully. This is something what we can understand nicely. Suppose this particular thing what you're seeing all around, this is the scalp. And the gray thing what you're seeing, suppose this is the bone. And beneath the bone will be the brain. Okay. So all this yellow what you are seeing here, this is the brain parenchyma. Injury to this yellow brain is called as primary. But with this injury, there are chances of injury to the blood vessels also, because of which they will bleed. And this blood can get collected here and there inside the brain. For example, the blue structure what you're seeing all around beta, this is the dura mater. Blue structure जो हमें दिख रहा है ये क्या है बेटा? What is this blue structure? This is the dura mater, right? Now, because of this injury, because of injury to blood vessels, there may be collection of blood here and there. This collection of blood which is outside the dura mater, this is epidural or extradural. This collection of blood which is beneath the dura mater, this is subdural. This collection of blood which is inside the brain parenchyma, this is intracerebral. In the subarachnoid spaces there may be collection, that is a subarachnoid hematoma or subarachnoid hemorrhage. So all these blood collections what we are seeing, whether it is extradural, subdural, intracerebral, subarachnoid, they are called as secondary brain injuries. तो बेटा प्राइमरी क्या था? जो ब्रेन पेरेनकाइमा को चोट लगी है वो प्राइमरी, और जो भी ये कलेक्शंस वगैरह दिखाई दे रहे हैं, हेमेटोमास दिखाई दे रहे हैं, ये सेकेंडरी. आई रिपीट दिस इन इंग्लिश बेटा. Whatever injury happens to the brain parenchyma, that is primary, and whatever collections of blood hematomas we are seeing here and there, they are secondary. Okay. Now, primary brain injuries can further be classified into three types: axonal injury, concussion injury, and laceration injury. Axonal injury, beta, what is an axon? Axon is actually a part of the nerve cell. If suppose only one nerve cell is getting injured, the patient may be absolutely fine. If more number of axons are getting injured, the patient may be confused. If more number of axons are getting injured, patient may go into coma. And if huge number of axons have been injured, patient may even die. That means patient can have a variable presentation depending on how many axons have been injured, what is the severity of injury to these axons. Patient may be normal, may be confused, may go into coma, or may even die. Since axonal injury is injury to the cell, if you look at this particular area or any area of your body, suppose we are taking the example of this particular area, right? Now, there are millions of cells in this area. If only one cell is getting injured and you are doing the scanning, you may not find anything on any scanning. Like if you're doing a CT scan for this area, if only few axons are injured, the CT scan will not show any injury. But in rare circumstances, suppose in this particular area, there are a lot of axons which are getting injured, then you might see some punctate pinpoint hemorrhages here and there. So diffuse axonal injury is something where we find a variable presentation of the patient and the CT scan majority of the times is normal. In 20% of the cases, we may see punctate hemorrhages. Another type of brain injury is concussion. जब भी कभी चोट लगती है बेटा सिर में, तो एक धमक लगती है. Whenever head injury is occurring, there is some hidden trauma to the brain. To make it a little simpler to understand, beta, if suppose I give a blow on my hand like this, now what has happened? I have hurt my hand here. That means I am having some pain here right now. Same thing can happen in head injury. If there is injury to the brain, there might be headache to the patient. There might be nausea type of feeling. There might be amnesia. He may not remember how the things have happened. So a patient who is coming to you with headache, nausea type of story, when you clinically examine this patient, suppose I give a blow here, I am hurt, I am having pain, I come to you and show you my hand. You are not able to see any injury here. There is nothing which you can make out. So you might feel that I am just malingering. आपको ऐसा लग सकता है कि मैं नाटक कर रहा हूं. But actually speaking, I have hurt myself. So I am having the pain. If suppose you do a CT scan of this area, the CT scan may also be normal. So even if the clinical examination is normal, the CT scan is normal, but patient is telling you that he is having headache, nausea type of thing, then you should not ignore these patients, beta. You should ask them to take rest, maybe for 10-15 days, adequately hydrate themselves, and then this headache will go off automatically. So that is how we manage the concussion injuries. Laceration injuries in the brain. Laceration term means that some part of the brain has got avulsed. अब सोचिए बेटा, अगर ब्रेन का कुछ हिस्सा नीचे से उड़ गया है, that means that part of the brain would have been controlling some neurological function of the body. Brain, we know, that is controlling the neurological functions. If some part of the brain get avulsed, that neurological function would be lost. Suppose that part of the brain is getting lacerated, which was responsible to control the movements of the right upper limb, then patient will not be able to move the right upper limb. This is what we call as a neurological deficit. Neurological deficit. So in laceration injuries to the brain, we find some or the other neurological deficit which persist for more than 24 hours usually. Okay? So let's see what we have written in the primary brain injuries. 3 types: axonal, concussion and laceration. देखते हैं बेटा जी क्या लिखा है इसमें. So primary brain injuries, they are diffuse axonal head injury, cerebral concussion and cerebral concussion and laceration. ये 3 टाइप की हैं बेटा. Now in axonal injury, there can be variable presentation depending on how many axons are injured. Patient may be normal, patient may be confused, may go into coma or may even die. CT scan is usually normal. Make a correction here, beta. Normal in 80% of the cases. However, in 20% of the cases, we may find punctate hemorrhages. CT scan would be normal in 80%. 20% we can find punctate hemorrhages. The other type of injury is concussion. Concussion is just like a hidden injury, जैसे गुम चोट लग जाती है. Patient may complain of nausea, headache and amnesia. CT scan would be normal. We cannot ignore these patients. We ask these patients to take adequate rest and hydration. Then third is concussion and laceration. Laceration, we saw that if some part of the brain is getting avulsed, the neurological function will be lost. So there will be a focal neurological deficit which persists for more than 24 hours. Focal neurological deficit which persists for more than 24 hours. This is about the primary brain injury. Now let's see the secondary brain injuries, beta. As we saw, there can be collection of blood inside the brain parenchyma, that is intracerebral, outside the dura mater, that is extradural, beneath the dura mater, that is subdural, in the subarachnoid space, that is subarachnoid hemorrhage, And many a times, because of these collections, the intracranial pressure would be high and the brain may herniate. So all these will be classified under secondary brain injuries. If we just go back and try to see, these different hematomas. Now here beta, in this particular image, we can very well see that this is the collection outside the dura mater. So we are calling this as extradural or epidural. This is the collection beneath the dura mater. So this is a subdural hematoma. Most often, subarachnoid hemorrhages are seen and subdural hematomas are seen. If we talk about each one of them, then epidural or extradural, this is collection of blood outside the dura mater but beneath the periosteum. This gray color beta हमने देखा था ना, we saw this gray color is the bone. So extradural कहाँ पे हुआ बेटा? Extradural कहाँ पे हुआ बेटा? Extradural is between the bone and the dura mater, while subdural is beneath the dura mater. Okay. Extradural hematomas beta, they are more commonly seen in the temporoparietal region in this area, and they are because of injury to middle meningeal artery. Which artery beta? Middle meningeal artery. Speak out, which artery is injured here? Middle meningeal artery, and this is a branch of maxillary artery. Okay. Can you tell me one thing? By looking at the screen beta, which hematoma you feel is farthest from the brain parenchyma? ये जो तीन हेमेटोमा हमें दिखाई दे रहे हैं ना बेटा, एक्स्ट्राड्यूरल, सबड्यूरल और इंट्रासेरिब्रल, इसमें से ये बताओ बेटा कि कौन सा हेमेटोमा ब्रेन पेरेन्काइमा से सबसे दूर है? कौन सा हेमेटोमा सबसे दूर है बेटा? विच हेमेटोमा इज फारदेस्ट? वेरी गुड, एक्स्ट्राड्यूरल. Right? So many a times what happens when injury has occurred and bleeding is taking place here, it will take some time for the bleed to increase. It will take some time for this bleed to put pressure on the underlying brain parenchyma. This particular time, when the bleed is taking time to put pressure on the brain parenchyma, the brain is normal. Patient is also normal. This transient period of consciousness after trauma, where the patient remains fully conscious, can carry out the normal routine activities, but will lose the consciousness after some time. This transient period of consciousness is called as lucid interval. And because the blood is outside the dura, it will take more time to compress the brain parenchyma, and this time the patient will be normal. That is why we say lucid interval is commonly seen in extradural hematoma. Lucid interval किसमें मिलता है बेटा? Lucid interval is seen in extradural hematoma. Now, 12th of December 2021, there was a single liner question. Lucid interval is seen in, and the answer was extradural hematoma. But if this question is repeated on 17th of December, beta, it will not be repeated like that most likely. The examiner will try to create different situations for you. You have to just try to make out whether the patient is losing consciousness after some time or not. He might give you different stories. Suppose he gives you a story of a disco party. The doctor, when this patient, or you can say the examiner may give you a story that doctor, there was a student in third year in Davao Medical School Foundation, Philippines. Now, he has gone to some disco on Saturday night and he's enjoying the disco party. Suddenly he see that there are two groups inside the disco who were having some fight, and suddenly one person hit the other person on the head, and soon after the injury, the other person actually collapsed. But soon the other person regained his consciousness, and then he started banging the person who was hit. And then the bouncer took the other person out, and the injured person who actually was hit on the head, he was normal, and he kept on enjoying the disco, and he was doing party whole night. But maybe after the party at 3 o'clock or 4 o'clock in the morning, he collapsed. Now the MCQ people will ask you, why, despite suffering injury in the head and collapsing at 3 or 4 o'clock in the morning, why he was able to enjoy the party between 11 p.m. to 4 a.m. Most likely he was having extradural hematoma, which took some time to expand and press the brain parenchyma. And this time, this duration, the patient was absolutely fine, enjoyed the party. This is what is lucid interval. So this type of story can be cooked on 17th of December, though they may not give the example of Davao Medical School Foundation as such, but yes. Another story what he can cook, there was a cricket match going on, and suppose there was a T20 match going on, and it was the 19th over, and the batsman was supposed to score maybe around 20-30 runs in the last 2 overs. Now, there was a fast bowler bowling in the 19th over, and the batsman removed his helmet, and suddenly the fast bowler hit a bouncer, and that bouncer hit the batsman on the head, and soon after that the batsman collapsed. But then he regained his consciousness, and he scored those 20-30 runs in the 19th and 20th over and won the match for his team. But soon after the match, the batsman collapsed. Now the MCQ people can ask, why the batsman was able to hit 20-30 runs in the last 2 overs despite having injury on his head? That is because there would have been extradural hematoma and the batsman would have been in lucid interval. Or he may cook a story of a construction site, that a building construction is going on, and suddenly the ceiling which was being laid, suddenly that ceiling fell down. Few laborers got injured. One laborer suffered from injury, but soon he regained his consciousness and carried out the building work, and maybe after 1 hour, 2 hours, he collapsed. So why he was able to carry out the building work even after suffering from head injury? Because he was in lucid interval. So I'm just trying to give you a situation, beta, that 17th of December, since this lucid interval is something which is one of the favorite questions of your examiner, the examiner may cook different type of stories. We just have to identify that whether the patient was conscious for some time, whether the patient was normal for some time after trauma or not. If this is a story, then this is lucid interval, and the answer for this should be extradural hematoma, right? Okay. Now, another important thing, beta, in extradural hematomas, when we do a CT scan, we see a convex type of hematoma. We see a convex type of hematoma. Herein, I would just like to tell you, beta, these are the CT scan images what you're seeing. ध्यान से देखिएगा बेटा इस फोटो को, ध्यान से देखिएगा एकदम. These images what you're seeing on the screen, these are hot image based questions. This image what you're seeing, beta, this is the first image based questions in the history of FMG exam. FMG exam के इतिहास में जब पहली बार इमेज बेस्ड क्वेश्चंस पूछना शुरू किए गए थे, तो पहला इमेज बेस्ड सवाल जो आपके एग्जाम में आया था 2015 में, वो ये आया था. This is an image of extradural hematoma. Since 2015, this image has been repeated thrice in the FMG exam. Now, let us try to understand. We are seeing some white thing here. White on a CT scan, white on a X-ray indicates there is some fluid collection, or if we are talking about trauma situation, must be some bleed. Okay? Just look at me on the screen and let us try to understand another small concept. Whenever we are doing X-ray or CT scan, we talk in terms of density. Whenever we are doing ultrasound, we talk in terms of echogenicity. Whenever we are doing MRI, we talk in terms of intensity. Then we can add the prefixes hyper and hypo. Hyper, anything brighter than the normal is hyper. Hypo, anything darker than the normal is hypo. I repeat this concept in Hindi beta. जब भी हम एक्सरे या सीटी स्कैन करते हैं तो हम डेंसिटी के बारे में बात करते हैं, अल्ट्रासाउंड पे इकोजेनिसिटी, एमआरआई पे इंटेंसिटी. हाइपर या हाइपो, अगर कोई चीज हमको ज्यादा सफेद दिखाई देती है तो हाइपर, अगर ज्यादा काली दिखाई देती है तो हाइपो, अगर बराबर जैसी दिखाई देती है तो आइसो. If it is almost equal, then it is ISO. So on X-ray and CT, we can say hyperdense, hypodense. On ultrasound, we can say hyperechoic, hypoechoic. MRI, hyperintense, hypointense. All fresh bleeds. All fresh bleeds. Look at me on the screen, beta. All fresh bleeds on X-ray and CT, they appear hyperdense. That means white. All fluids or bleeds on ultrasound, they appear darker. That is hypoechoic. यानी कि एक्सरे और सीटी स्कैन में अगर फ्लूइड या ब्लड है और खासकर अगर फ्रेश ब्लड है तो ये सफेद दिखाई देता है, और अल्ट्रासाउंड पे जो फ्लूइड, पानी, ब्लड, ये काला दिखाई देता है, हाइपोइकोइक. राइट. दैट मीन्स trauma to any part of the body, if you are doing X-ray or CT, if there is bleeding, that will appear white or hyperdense. Right. That is why these hematomas, whether extradural or subdural, what you are seeing, they are more white, they are hyperdense. Okay, this is also hyperdense. This is a picture of extradural hematoma and this is a picture of subdural hematoma. There is slight difference what you can see. One thing which is common, the outer surface, this particular surface where there is bone, this is convex. Here also, this particular surface of the bleed is convex. Okay? But this surface of the bleed in extradural hematoma, you are seeing this as convex. While in a subdural hematoma, you are seeing this as concave. That means extradural hematoma appears biconvex. Convex here, convex here. Subdural hematoma appears convexo-concave, or you can say concavo-convex. Why this is so? And the simple reason is, it is because of the attachment of dura mater. Now, beta, dura mater, we know, let us use the blue color for dura mater. Dura mater is attached to the bone at different points. Suppose the dura mater is attached to the bone here, like this. Now, this is the dura mater which I am trying to draw, and then let us try to create the bleeding and let us try to understand. Now, suppose this is the dura mater here. If I say there is bleeding outside the dura mater, that means there is bleeding here. Now, what is going to happen? This blood is going to get collected like this. Outside is the bone beta. Okay. And gradually this blood will try to push the dura mater inside. Dura mater will be pushed inside. So dura mater is being pushed inside. But because of the attachment of the dura mater with the bone, the dura mater will be seen something like this. That is why this hematoma, what we are seeing, this looks like a lenticular hematomas or a biconvex hematoma. Or you can say that it is like a orange type of hematoma, right? If we look at the subdural hematoma, suppose I try to create a subdural hematoma here. If suppose there is a bleeding beneath the dura mater, look at the screen carefully, beta, look at me. Yes. Now, if there is a bleeding beneath the dura mater, what is happening here? The blood is going to push the dura mater outside. So the dura mater is being pushed outside. That is why the blood is seeping nicely beneath the dura mater. So now beta G, if you compare this side and compare this side. So this border, what you are seeing here, this is a convex border. But this border, what you are seeing here, this is a concave border, right? So this looks like a crescent, like Eid ka Chand, right? The moon, the crescent moon on the Eid, right? So this is like a crescent. Or you can say that this is like a banana, right? So banana-like hematoma is subdural, while orange-like hematoma is extradural, right? So that is how we understand the concept why extradural looks like biconvex and why subdural looks like a concavo-convex. Okay, beta? This is what we have to remember. Now let's take a look what all is written here. So in these different hematomas, EDH is epidural hematoma, or we can say this as extradural hematoma. There is collection of blood outside the dura mater beneath the bone, most commonly seen in the temporoparietal region. Most common cause is injury to middle meningeal artery. This middle meningeal artery is a branch of maxillary artery. Sometimes there can be injury to transverse or sagittal sinuses also, which can cause this extradural hematoma. And as we discussed, lucid interval, which is a transient period of consciousness after trauma, where the patient remains fully conscious and can carry out the normal routine activities before he loses the consciousness. This lucid interval is commonly seen in extradural hematoma. Investigation of choice is a CT scan. This is a non-contrast CT scan. Non-contrast CT scan, where we find hyperdense convex, or we can say lenticular. Sorry, lenticular, or you can say orange-like. This is what we see in extradural hematoma. Now here, beta, in your workbook, I hope you will be able to appreciate the hematomas. This is a biconvex. This is a extradural hematoma. Here also, if you carefully take a look, This border is convex. This is actually a case of bilateral frontal extradural hematoma. So this is the hematoma what you are seeing. This is a bilateral frontal extradural hematoma, right? Okay. Now, if we talk about subdural hematoma, subdural, this is also referred to as boxer's hematoma. This is collection of blood beneath the dura mater. This is due to, now D/T, this is due to injury to cortical bridging emissary veins. Injury to cortical bridging emissary veins. When we are doing non-contrast CT scan, non-contrast computed tomography, we find it to be hyperdense concave, or we can say concavo-convex, or we can say lenticular. No, not lenticular beta, crescentric. 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 Or you can say it like banana. So subdural appears concave or convex, or crescentric, or like a banana. And we can classify these subdural hematomas. Here I hope you are able to see how this is looking concave. Right? This surface is concave. Okay. We can classify these subdural hematomas into acute, subacute, and chronic. Acute is 0 to 3 days duration, 4 to 21 days subacute, and after 21 days chronic. Now herein I would like to specify beta acute and chronic. These are two terms which are very commonly used in various medical subjects, in all the 19 subjects. Acute is simply which is sudden in onset, severe in presentation. But the best part is it also passes off quickly. Sometimes it is associated with high mortality also. I repeat this in Hindi beta because this acute term is something which is being commonly used. So how we have to create an impression whenever acute thing is mentioned in our exams or maybe in our clinical practice. Acute का मतलब होता है बेटा अचानक से आती, अचानक से आई, पहले कोई वार्निंग सिम्टम्स नहीं थे, अचानक से आ गई और खतरनाक तरह से प्रेजेंट करती है, पेशेंट को पूरी तरह से हिला देती है, घर वालों को भी हिला देती है. लेकिन अच्छी बात क्या है, जितनी तेजी से आती है उतनी तेजी से ही चली भी जाती है, कभी कभी ले भी जाती है. So whenever we are managing or dealing with these acute conditions, the time factor is very important. We have to be very aggressive in the management. Otherwise, we might even lose the patient. Patient may lose his life, right? So we have to act accordingly. While chronic is something which is present there for a long period of time, sometimes it can show us that yes, there is something, and we have to investigate the patient and we have to plan the treatment on an elective basis. I repeat this in Hindi बेटा. Chronic जो होता है बेटा, ये कुछ ऐसा है जो महीने सालों से पड़ी होती है. अब जैसे मान लीजिए गॉल ब्लैडर में पत्थर है, सालों से पड़े हुए हैं, बीच बीच में अपने होने का एहसास करा देते हैं, मीठा मीठा दर्द होता है राइट अपर एब्डोमेन में, पेशेंट जो है डॉक्टर के पास चला जाता है, डॉक्टर एग्जामिन करता है, इन्वेस्टिगेशन करा लेते हैं, पत्थर आ जाते हैं और फिर प्लानिंग कर लेते हैं कि भैया इसका करना क्या है, निकालना है तो कब निकालना है, महीने बाद निकालना है, 6 महीने बाद निकालना है, साल बाद निकालना है, 5 साल बाद निकालना है, वो प्लानिंग हो जाती है. So chronic is something which is present there for a long period of time. Patient usually comes to us in the OPD, outpatient department. We can examine the patient nicely, we can investigate the patient nicely, and then we plan a elective treatment for that. Now here, if we try to correlate the acute and chronic stories, immediately after the injury, it is acute. But gradually what will happen? The hematoma will start resolving. And a stage may come when the hematoma will be completely resolved. Okay? So this is the story about important hematomas inside the brain. Now comes how to manage the head injury patients. How to manage these brain injury patients. For that, let us take a look once again at this particular image. Now in this particular image, beta, what we are able to understand, whenever there is any collection of blood here, right, the pressure inside the brain is increasing. ध्यान से सुनना बेटा, be careful. Whenever there is any collection inside the brain, whether there is collection of blood, air, water, tumor, any collection inside, we know that brain is surrounded on all sides by the bone. So whenever there is some extra guest coming here, there will be fighting for space inside. That means the intracranial pressure is increasing. And if the intracranial pressure is increasing, this high pressure inside the cranium is going to put pressure on the blood vessels. So the blood vessels will not be able to supply adequate oxygen to the brain. And then the brain will suffer from hypoxia. And my dear doctors, the duration of hypoxia to the brain is directly proportional to irreversible brain damage. I repeat, the duration of hypoxia to the brain is directly proportional to irreversible brain damage. I repeat this in Hindi beta. हम जानते हैं कि जो ये ब्रेन है इसके चारों तरफ हड्डी है. जब भी इस इलाके में कोई मेहमान आएगा, चाहे वो ब्लड आ जाए, पानी आ जाए, या ट्यूमर आ जाए, या हवा आ जाए, तो इसके अंदर प्रेशर बढ़ने लगेगा. और जब जब इंट्राक्रेनियल प्रेशर बढ़ेगा, तब तब ये जो ब्लड वेसल्स ब्रेन को सप्लाई कर रही हैं, इनके ऊपर दबाव पड़ने लगेगा. और अगर उन वेसल्स के ऊपर दबाव पड़ने लगा तो ब्रेन को ऑक्सीजन की सप्लाई ठीक से नहीं हो पाएगी. और जितना ज्यादा समय ब्रेन को ऑक्सीजन की सप्लाई नहीं होगी, उतने ही ज्यादा चांसेस बढ़ जाते हैं कि ब्रेन के उस हिस्से में जिंदगी भर के लिए बर्बादी हो जाए. आप डॉक्टर हैं, यू आर द डॉक्टर. It is the responsibility on your shoulders to ensure that patient should not develop any irreversible damage. We can understand if suppose that part of the brain gets permanently damaged, which was responsible to control the speech of the patient. Patient will not be able to speak throughout his life. If that part of the brain suffers from irreversible damage, which was responsible for controlling the movements of bladder and bowel, patient will develop a urinary and fecal incontinence for the whole life. So my dear friends, my dear doctors, in the management of head injury, this concept is very important. We do not want hypoxia to the brain. We do not want this duration of hypoxia to increase. That means we do not want intracranial pressure to rise. Even if it rises, we try to reduce the intracranial pressure so that the pressure on the blood vessels which are supplying oxygen to the brain is not much, and oxygen can be supplied to the brain cells. That means we want to increase the blood flow to the brain cells We want to increase the cerebral perfusion pressure, and that is possible if we can reduce the intracranial pressure. My dear doctors, this is the reason why we keep on talking about mannitol in head injury. We understood the concept that if the intracranial pressure is high, the cerebral perfusion pressure will be low. That means the oxygen supply to the brain will be less. Hypoxia to the brain will be more. So we reduce the intracranial pressure so that cerebral perfusion pressure can increase and we can avoid hypoxia to the brain. Normal intracranial pressure is somewhere between 8 to 12 millimeter of mercury. More than 22 intracranial pressure is dangerous to life. We try to keep this intracranial pressure less than 20 millimeter of mercury, right? We can use various medicines like mannitol, diuretics. If mannitol and diuretics are not able to reduce the intracranial pressure, then you can take a drill machine, the drill machine which we use to drill the hole in the wall, right? We can use the drill machine and we can put the drill machine here and go right into the brain and evacuate the hematoma so as to reduce the intracranial pressure. That is, we can create holes into the cranium which we call as burr holes. Or you can take a hammer and chisel and you can just open the bone flap, just raise the bone flap. As soon as you raise the bone flap, the pressure cooker situation inside, as soon as you raise the bone flap, the inside pressure will be released, the hematoma will be out. So that is how we can decrease the pressure on the blood vessels supplying oxygen to the brain cells. Opening something in surgery is called as stomy. Opening the thorax is called as thoracotomy. Opening the abdomen is called as laparotomy. Opening the cranium is called as craniotomy. So a decompressive craniotomy is also something which we can use to reduce the intracranial pressure. Lumbar puncture, in order to reduce the intracranial pressure, is not the right thing, because if you put a needle into the lumbar space, maybe L3, L4, L4, L5, and try to drain the CSF, as soon as the CSF starts coming out, the brain comes to know, oh, there is a window somewhere which has opened and there was high pressure inside the brain. Brain comes to know there is a window somewhere, so the brain can also try to herniate down through the foramen magnum. To avoid this cerebral herniation, it is better to avoid lumbar puncture as much as possible. Right, now let's take a look what all is written here. In the management of head injury, our aim is to reduce the intracranial pressure so that we can increase the cerebral perfusion pressure. Normally, intracranial pressure is between 8 to 12 millimeter of mercury. We can call this as 10 millimeter of mercury. Value of more than 22 millimeter of mercury for intracranial pressure is dangerous. So as a doctor, we try to keep this ICP below 20. By doing this, we can increase the cerebral perfusion pressure. CPP is the cerebral perfusion pressure, that is the pressure with which the oxygen is getting supplied to the brain. This is mean arterial pressure minus intracranial pressure, and our aim is to keep it above 65 millimeter of mercury, or at least more than 60 millimeter of mercury. CPP. Then we are able to deliver oxygen to the brain cells. To reduce the intracranial pressure, we can use mannitol, which is an osmotic diuretic. This was a pharmacology question in December 21. We can use diuretics. Now, if you just leave this particular area and move to the next page, beta. If ICP is not controlled with medicines, we can create burr holes, we can do decompressive craniotomies. Lumbar puncture is best avoided. Lumbar puncture is best avoided. So that is how we try to reduce the intracranial pressure. Herein, the fluid management is not something which is important in head injuries. Just try to imagine, beta, just try to close your eyes. Just try to close your eyes and imagine that if there is trauma to the brain versus trauma to the abdomen, maybe to the liver or to the spleen, which patient will have more chances of losing huge amount of blood? Brain traumas or liver spleen traumas? Yes, liver and spleen traumas, because there the bleeding is going directly into the peritoneal cavity, which is a big cavity. So the chances of patient going into hypovolemic shock will be more in liver and splenic injuries. But a patient of head injury, because the brain is surrounded by the bone on all sides, so even if there is an extradural, subdural, subarachnoid, intracerebral hematoma, the bleeding is not that much, which can lead to hypovolemic shock. That is why we say that fluid management is not that aggressive in these brain injuries, right? Okay, just give me a moment. Right, beta. So fluid management is not that aggressive here. However, when we have to give the fluids, we use the crystalloids, the normal saline and the ringer lactate. We can also use hypertonic saline. But in head injuries, dextrose-based solutions, dextrose, that means glucose-based solutions, should be avoided, because hyperglycemia is harmful to the brain. Hyperglycemia is harmful to the brain. Hyperglycemia is harmful to the brain. We have been talking about in saving the life of the patients whenever there is bleeding. First we pump in crystalloids, then we pump in blood products. We can give tranexamic acid injection, first dose within 10 minutes, preferably within 3 hours, and second dose to be repeated in 8 hours, right? If this does not help, then we have to do surgical exploration. So this is just a reminder. However, this is not very much needed in head injuries. Generally in hypovolemia, there is tachycardia and hypotension. But in head injuries, there is bradycardia and hypertension. If patient is already taking some medicines previously like aspirin, you have already written earlier, you give platelets. If patient was taking warfarin, then you can give vitamin K and fresh frozen plasma. If patient was taking heparin, then you can give protamine sulfate. Just to counter these medicines, just a revision of what we have discussed earlier. Right. So this is all about the story of head traumas. Quickly, if we take a look what all we have discussed here. First, we started with the story of disaster management. In this disaster management, we followed the disaster management guidelines. Quick response teams to the disaster site. They gave the first aid, transported the patients back to the hospital, where you doctors, you have got a nice team with you, and your aim is to save the life. Do a primary assessment A, B, C, D, E, save the life first, and once the life is saved, then you go ahead with the secondary survey. So in ABCDE, you have to secure the airway. You have got different options in securing the airway. Breathing, you have to achieve adequate lung expansion, so you can drain the collection or you can put the patient on ventilator if the muscles are paralyzed. This is the image of the ventilator which is shown here, or you can say the anesthesia machine. And then in the circulatory management, you know that if the patient is bleeding, the heart rate will become faster, the cutaneous vasoconstriction will occur, and if more than 30% of blood loss has occurred, then patient systolic BP will start falling down. If the BP starts falling down, then oxygen supply to different parts of the body will be hampered, so you have to pump in IV fluids quickly. Crystalloids, normal saline is something what we are pumping. There was a request which I received that I should explain this in Hindi, why we don't use colloids. So beta, just to ensure that request here, I'll explain in Hindi why colloids should not be given in the initial period of resuscitation. देखिए बेटा, अगर मान लीजिए ये ब्लड वेसल की दीवार है और यहाँ से ब्लीडिंग हो रही है, तो ब्लड पूरा बाहर निकल रहा है, हम इंट्रावेस्कुलर वॉल्यूम धीरे धीरे कम होती जा रही है. अगर इंट्रावेस्कुलर वॉल्यूम कम हो रही है, इसका मतलब कहानी कुछ ऐसी सी हो रही है, यानी कि जो ब्लड वेसल की दीवार पे प्रेशर पड़ रहा है वो कम हो रहा है, यानी ऑक्सीजन सप्लाई जो हो रही होगी अलग अलग सेल्स को बॉडी में वो कम होती जा रही होगी. अगर मान लीजिए ऐसे हालात में हम कोलॉइड्स देते हैं, तो कोलॉइड्स भी यहाँ से लीक करेंगे. कोलॉइड्स में प्रोटीन्स होते हैं, और अगर मान लीजिए ये प्रोटीन बाहर आ गया वेसल से, तो प्रोटीन की एक क्वालिटी होती है कि ये ऑस्मोटिक प्रेशर एक्सर्ट करते हैं. अगर मान लीजिए प्रोटीन वेसल से बाहर निकल आया और यहाँ पे आके इसने ऑस्मोटिक प्रेशर लगाया, तो इसका मतलब ऑस्मोसिस से ये वेसल के अंदर जो भी सामान है उसको और बाहर की तरफ खींचेगा. हम तो ये चाहते हैं कि यहाँ का प्रेशर बढ़ जाए, यहाँ पे पानी ज़्यादा हो जाए, जिससे कि ऑक्सीजन जो भी है वो पूरे शरीर में जा सके. लेकिन कोलॉइड देने से अगर ये कोलॉइड लीक करता है और प्रोटीन बाहर आ जाता है, तो प्रोटीन अपने ऑस्मोटिक प्रेशर की वजह से जो भी वेसल के अंदर का सामान है उसको और बाहर की तरफ खींचेगा, यानी कि अंदर का प्रेशर, अंदर की वॉल्यूम और कम हो जाएगी. इसलिए कोलॉइड को शुरुआत में नहीं देते हैं. जब तक ये फ्लूइड, जब तक ये लीक परसिस्ट करता है, तब तक कोलॉइड नहीं दिया जाता. Then we talked about how we can put 2 wide bore IV cannulas and we can give 1 liter normal saline within 1 hour quickly. Just to ensure, just to restore the intravascular volume, we can use different color cannulas. एक बार बेटा फटाफट से quickly, can you revise the coding of the color cannulas? Yes, orange, gray, green, pink, blue, yellow, violet. एक बार दोबारा से बोलेंगे बेटा. Once again. Very good. And then 14 gauge to 26 gauge. So we give the fluid through these wide bore IV cannulas. We monitor the fluid resuscitation by urine output. If needed, we can pump in blood transfusion of various blood products. We can give tranexamic acid to stop the bleed. If nothing is helping and the patient is still bleeding on, we have to put direct pressure on the bleeding vessel. So we have to do immediate surgical exploration. We can do the disability assessment by Glasgow Coma Scale, eye, verbal and motor responses. Eye, verbal, motor, electronic voting machine, 4, 5, 6, 4, 5, 6. Total maximum is 15. Minimum is 1, 1, 1. Total minimum is 3. Moderate is 9 to 12. Eye 4, spontaneous 3, 2, 1. Verbal 5, 4, 3, 2, 1. Motor 6, 5, 4, 3, 2, 1. Right. So that is how we can assess the disability. And then in the exposure, we have to take care of hypothermia. We have to use warm fluids and warm blankets. We can segregate the patients into different categories after doing this A, B, C, D, E. Red, yellow, green, black. Red, immediate. Yellow, early. Green, ambulatory, can wait easily. And black is someone who has died. White is an ambulatory patient who does not even require hospital care. Once we have done this triage also, once we have saved the life, then we do a secondary survey, detailed history, examination, investigation, and treatment. In the history, we should not forget about 5 things: ample, A for, M for, P for, L for, E for. Right. Then we talked about the head injuries. We talked about that there are 3 things inside our head: scalp, bone, and brain. In the scalp, loose aerial tissue is the most dangerous zone. So we should not take these scalp wounds lightly. We should irrigate them nicely and close them in 2 layers. In the bone, we talked about different fractures: linear, depressed, base of skull, Pons fracture, and the orbital blowout fracture. Then we talked something about brain injuries, the primary and secondary. In primary, we talked about axonal injury, concussion, and laceration injuries. In secondary, we talked about different hematomas: intracerebral, extradural, subdural, subarachnoid, and cerebral herniation. We discussed why lucid interval is seen in extradural. We discussed why the hematoma in extradural appears hyperdense biconvex and why hematoma in subdural appears hyperdense concavo-convex. And then we talked about that in the management of head injury, we have to increase the oxygen supply to the brain cells. For that, we have to reduce the intracranial pressure, for which we can use mannitol or diuretics, or we can create Burr-Holz decompressive craniotomy. Lumbar puncture is best avoided in these situations. Thank you very much for your patience, Peter. Thank you very much for your patient listening. May God bless you all. Just remember one very small thing which I would like to tell you, that you have already completed your graduation, right? You have already fought with so many challenges in your life, right from the tender age of 17 or 18, when you first took the international flight outside. You were very small. You went into a country where you did not understand the language properly, where you did not understand the food habits there, where you did not know from where you are going to get your meals, where you were not aware about the climatic conditions, that you might have to survive at some extremely low temperatures also at times, where you were not comfortable with the education system also. But my dear doctors, believe me, you have got a great personality. If you have the capability to fight out with those challenges and come out with flying colors and complete your graduation, these 5 months, or maybe 7 days less than 5 months, just keep that fire inside your belly. Just keep on thinking the sacrifices which you have made in the last 6 years. Just keep that fire intact inside you. Just keep yourself dedicated. Just keep yourself focused, concentrated. Be honest to yourself. Keep on studying on a daily basis. Small efforts on a daily basis that will keep you pumped up, that will give you the confidence. And let us stay positive throughout this journey. Let us motivate each other throughout this journey. Let us try our level best to help each other wherever possible. And believe me, my dear friends, if you remain consistent, if you remain honest to yourself during this journey, nobody on this earth has the power to defeat you. Even you will not be able to defeat yourself. And you will definitely be coming out with flying colors on 17th of December. Keep believing in yourself. If you have done that, you will be doing this also, and nobody will be able to stop you. Thank you very much. God bless you. Have a great day ahead. And now the house is open for any queries. Please do write in the chat box of the application, and I would be happy to answer each and every query right now. Right. So in the doubt group, Abhinav, you cannot ask the doubt and watch the explanation simultaneously. You have to come out of the video section, write your query in the doubts, in the chat section of the application of your batch, and then you have to come inside the video. Both cannot be done simultaneously. Right. So by the time I'm receiving the queries in the chat section of the app, let me just see the chat section once again. Yeah, so I think I've got some time to respond to the WhatsApp queries. Let me try to respond to the WhatsApp queries. Muhzina from Wuhan. Can I please know when this ring elected preferred as IB? Muhzina, ring elected is preferred in burn patients over normal saline. Otherwise, at all the other places in hypovolemia, normal saline is the first fluid of choice for initial resuscitation. Till the time the blood vessels remain leaky, we prefer giving crystalloids once, maybe in few hours or maybe 24 hours or 36 hours. When the vessel leak has been sealed, then we can give colloids. Thank you, Anisha. Thank you so very much, Beta, for such nice messages from your side. Salim from Northern State Medical University. Beta, hypertension is a late sign of hypovolemia. Why we say that blood pressure fall is little later? Because as soon as the trauma has occurred, as soon as the bleeding has started, then first thing what the heart is trying to do is heart is trying to contract faster and faster and is trying to maintain the blood pressure. But when the blood is continuously getting lost and say more than 30% of the blood volume has gone out, then even that pumping of the heart is not sufficient to generate that much of pressure inside the blood vessel. That is why we say that initially earliest is tachycardia, then cutaneous vasoconstriction, and a little later is hypotension. I hope, Salim, you got the answer. Pavi, GCS is quite reliable. We keep on doing this GCS, though there have been a lot of modifications coming up in GCS, like a GCS P score is also there. But yes, GCS is something which we are commonly using in these situations wherever there is trauma or bleeding. RF from Sumi, as we know, O positive is universal donor, but here transfusion by O negative. Basically, RF, if you say O positive, positive means what? The Rh antigen is present, but O negative is what? When the Rh antigen is also not there. So, apart from the A and B antigens on the RBCs, we are also trying to minimize the Rh antigen induced antibody reaction in the recipient. That is why O negative would be preferred over O positive as the universal donor. Uh, Hitesh from Kazakh National Medical University, I suppose, KNMU. If all EVM in Glasgow Coma Scale is not testable, then how we can assess the patient? If you cannot assess the eye, verbal and motor, then you will not be able to assess the Glasgow Coma Scale at all. However, motor response is something which we can definitely assess. Eye responses and verbal responses are something many times we cannot assess. If you are not able to assess any response, or if the patient is not showing any response, Hitesh, then probably the patient would have died, or would almost be in the process of dying. Beta, the last five digits of your number 99038. Please do mention your name and university. You have a doubt that GCS score of a patient having intracranial hemorrhage is at 3. See, if the score is 3, then either the person has died or it is a state of severe coma. Hello, Samrit from Kiev Medical University. How can I help you, Samrit? The last five digits 32743. Please do mention your name and university, beta. Unnati from Orenburg. Why we normal saline in metabolic alkalosis and no colloids? Generally, when we say crystalloids and colloids, we are talking about a situation where the patient is actually bleeding. So, what is happening beta? Oxygen deprivation is taking place to different cells of the body. So, if oxygen is not going into cells, aerobic respiration would not be taking place. Anaerobic respiration will be taking place. And the byproducts of anaerobic respiration are lactic acids, pyruvic acids. So, the amount of acid would be increasing inside the patient, that is metabolic acidosis. And we are just trying to pump in crystalloid solution in these conditions. Ishan from VN Karazina, beta CSF is transparent, right? So it is not dark. It is the brain parenchyma. What you're seeing is a gray color on CT scan, Ishan. Now let me just see the chat section in the application. If any one of you have typed your queries in the chat section. Yeah, so I'm able to see. Abraham Lincoln, hi to you, beta. Abhinav, GCS of mist management in morning. I couldn't get you. Next topic, Abraham, if you would have seen the schedule, it will be tomorrow morning, 9 o'clock. Oh, sorry, tomorrow is Tuesday, so Tuesday we are not having any other classes in the online. So Wednesday morning, 9 o'clock. Abraham, regarding pneumo and hemothorax, I think let us wait till Wednesday morning, because there we'll be talking in detail about pneumo and hemothorax. We'll be seeing the x-rays also there, and we'll be discussing pneumo and hemothorax in pretty much detail there. Blood transfusion, which is the first choice. Tranexamic acid can be given immediately, Lasa Priya. Pooja, very good afternoon to you. You are from South Kazakh. In the triage red bands, I read somewhere interval must be given within 1 hour, and you told us within 6 hours. According to the surgical books and according to the ATLS guidelines, Pooja, we should be doing it as early as possible, preferably within 1 hour. If we are not able to intervene within 1 hour, then according to preventive and social medicine, we can intervene within 6 hours. Savan Gajera, can be discussed regarding subarachnoid hemorrhage. Savan, subarachnoid hemorrhage is something which your forensic faculty would be discussing in detail. However, here, wherever there is blood is getting collected in the subarachnoid space, that is what is subarachnoid hemorrhage. It can be related to trauma. It can be related to rupture of aneurysms. For example, rupture of Barry aneurysm, which is the aneurysm of circle of Willis. We can find that bleed in the subarachnoid spaces. Depending on how much is the collection, how much the pressure is there on the meninges, the patient presentation will be according to that. Patient may have headache, patient may have nausea, vomiting. Sometimes the patient may feel a bit dizzy in subarachnoid hemorrhage, and depending on how fast the hemorrhage is resolving, the patient condition will improve according to that. Srashti, yes, intracranial pressure. We are talking about this intracranial pressure. That is the pressure because of the skull bone over the brain parenchyma. Right, so normally it is 8 to 12 millimeter of mercury, but whenever there is any collection inside, that increases the pressure inside the cranium, and that puts the pressure on the cells, on the blood vessels which are supplying oxygen to the brain cells. So the perfusion, the oxygen supply to the brain cells will decrease, and that will cause hypoxia. Pooja, thank you so much. Abhinav, there won't be any test of the previous day topic, but yes, there will be a test on every Tuesday. And the syllabus to be asked on every Tuesday would be the syllabus covered between Monday to Sunday. Ali Datta in GCS to check the ISCO 2, do we have to apply pressure only on the, or we can press any part of the body. Generally, around the eye is what we are preferring. How many days it will take to finish surgery? Abhinav, it will take approximately 10 to 11 days. Ali, is it possible to have EDH without any lucid interval? Yes, it is very much possible that EDH does not have a lucid interval at all. Abhinav, tranexamic acid second dose given 8 hours after first dose or 8 hours after admission in the hospital. preferably 8 hours of admission in the hospital. Akshay Krishnan from Smolensk. Very good afternoon to you, beta. Can you give us some guidance for time management, how to revise past class so we can remember everything we studied? And whatever our sir and madam taught us, can you please give some guidance in the next class? Thank you, beta. Thank you for your kind words of appreciation. Akshaya, I would just like to tell you, beta, that we have to make a 20th copy. We actually have to make a 20th copy, wherein Akshay, we have to make a 20th copy wherein on a daily basis, whatever topics are being taught to us, you have to identify those areas which you feel that you are going to forget it very soon. So just write that particular area in that 20th copy. For example, in today's class, we talked about GCS. We talked about the color coding of cannulas. So in that 20th copy, you just have to mention GCS. Don't write the complete score there in the 20th copy. Just write these three letters GCS, and then you can write something like the color coding of cannulas, so that every day, whenever you wake up in the morning, first 15 to 30 minutes, you have to devote time for this 20th copy. Just try to revise that quickly as early as possible. And probably if we are doing this on a daily basis, then by the month of October and November, we will be much better equipped and we will be able to have a better recall in these questions. Ruturaj from Karazina. Basically, revised trauma score is something systolic blood pressure, which you can measure with a BP cuff. Respiratory rate is the movement of the rib cage, what you're seeing. And the Glasgow Coma Scale is something what we have talked about in detail. Regarding ISS, that is Injury Severity Score, that is an anatomical scoring of trauma, wherein we have to grade the injury based on the investigations what we are doing later on. The last 5 digits 94234, the brain laceration, it is simply avulsion of the brain parenchyma beta, and herniation of the brain can occur whenever the intracranial pressure is high. It is going to put pressure on the brain parenchyma, and there is a risk that the brain parenchyma may herniate through the foramen magnum. Please do mention your name and university beta. Thank you so much, Samrat, for your kind words, beta. Can you just mention your university so that I can save you in my contacts? Aishwarya from Three Georges. You are giving a scenario when somebody fell from the bed, but within 10 days he got absolutely fine. Should we go for an MRI or not? I don't think if the patient is absolutely fine, there is any need for any further scanning. We can just observe for another 2 weeks, 3 weeks time. Generally, the head injury hematomas, they take around 3 to 6 weeks to resolve completely, and that should be absolutely fine. There is another query from Aishwarya. Lady got hurt in bus by a pole on sudden brake applied by driver. The injury was on suborbital process, 3 centimeter from cribriform frontal process. She had acute concussion, swelling, and no confusion. Composed. She is known case. She went to hospital. What should be the first line of management in intern in government hospital? We need to observe this patient for 24 hours. We need to also see that if the patient is taking some medicine, maybe Ecosprin or something, if that is being taken, then we have to stop that medicine quickly. Thank you, Beta. Thank you so much. So nice words of appreciation. 67416. Beta, please do mention your name and university. Sampath, how to differentiate between orange and gray, because both for shock and both are white. The color, the cannula color. Orange color is 14 gauge and gray color is 16 gauge. Khushbu from SEMI, what is a definitive REAC in secondary survey? Definitive treatment, beta. For example, in head injury, right? If we are creating a burr hole for evacuation of some hematomas, that is what is the definitive treatment. Tara from Bogomolets, there is a situation in many movies that bleeding from ear may lead to death after some time. Is it related to lucid interval? Probably, if there is bleeding going on from the ear, Tara, then maybe there is a big hematoma which is expanding inside. So, because it is expanding inside, the bleeding is increasing and it is putting pressure on the brain parenchyma. The intracranial pressure would be increasing, and then it would be decreasing the supply to the brain cells, and probably because of hypoxia, the patient is dying. Hypoxic injury to the brain. Anandita Maiti from Kiev. Why concussion is causing headache? Anandita, just a small thing which I would like to tell you, that if you give a blow to any part of your body, then definitely that is going to hurt you. So probably it is due to injury to the tissues which causes accumulation of substance P, and that is responsible for pain like headache. And it is because of the pressure inside, pressure on the brainstem, that patient would be having nausea. Anish from KNMU. Epidural hematoma is only convex, subdural is only concave. Epidural is biconvex and subdural is concavo-convex. Rias from Northern State Medical University. If a man is deaf and blind, how to calculate GCS? Then we will not be, see, if he's blind, right? then he might be obeying the voice commands, he might be obeying the pressures, so eye response can be assessed. But if he's deaf, then yes, voice commands, he will not be able to respond to the voice commands, so we will not be able to assess the eye scoring in that. Motor scoring can be assessed in those cases. Krishna, this tranexamic acid is actually epsilon aminocaproic acid for uncontrolled bleeding. This tranexamic acid is almost the same thing. And Krishna, I would be happy if you can just mention the name of your university. Thank you so much, Pavi. Yes, aminocaproic acid can easily be used. Thank you, Hari. Please do mention your university, beta. Rohit from Karasina, could you please tell what kind of appearance we see on CT if there is subarachnoid hemorrhage? It looks hyperdense, and you would be seeing the hyperdense shadows in the ventricles. Thank you so much, Arif. Thank you, Hitesh. Abraham, I hope I have answered your questions. If you are watching the live class, if not, just go back to the replies when I started doing that at around 2:18 p.m. Thank you, Gaurav. Thank you so much, beta. Wish you all the very, very best this time. Just stay focused and dedicated. Just keep on studying extremely, extremely hard. Thank you so much, Samrit. Thank you very much. God bless you, beta. Thank you, Shinu. Vidya, nasal intubation should not be done in anterior cranial fossa fracture because if suppose there is a breach in the bone between the brain and the nose and you're putting a tube there through the nose, if there is a break in the bone, the tube might increase the injury, and there is a risk that tube can migrate up into the brain. Vidya, it would be good if you can mention your university beta so that I can save you in my contacts. I hope, Pooja, you have got your answers. I hope, Avinav, you have got the answer, beta. Thanks, Ishant. Thanks so much, beta. Tarun from Orenburg, uh, please tell about burr holes. Do we have to do these holes till the hematoma levels in cases except extradural? Burr holes have to be created to evacuate the hematomas and to reduce the intracranial pressure. Definitely, if there is extradural hematoma, we have to just drill through the bone and we are into the hematoma straight on. But if the hematoma is beneath the dura mater, definitely there is risk of causing injury to the dura mater and to the brain parenchyma as well. So we have to weigh the pros and cons, whether by creating the burr holes we are going to cause more damage to the brain parenchyma, or we are actually going to cause more relief to the patient by draining that hematoma. So that is totally dependent on weighing the risk and benefits. Then only we create the burr holes in any hematoma which is beneath the dura mater. Generally, this is Mohzina from Wuhan. Does the head injury of an infant of low risk since the skull is not fully developed? Beta, you can just move out of the classes if you have got another class coming up at 3 o'clock, because what I'm doing is when I'm responding to your messages, I'm also using the speaker so that I can send you a voice note. So there is no need of sitting in the class right now. If you just want your query to be answered, so I'm using the voice note as well while answering to your queries. Mohsina, in infant, since the skull is not fully developed, yes, there are chances of more injury. Periorbital hematomas, generally they resolve spontaneously unless and until they're causing more damage to the eyes, which is not usually the case. Sandeep from Harbin, due to health issues, you have to change from offline course to online, and I think it's great. Thank you. Since you have switched from offline to online and you are finding online great, yes, beta, online classes have got their own advantages. The only thing required is your commitment and dedication, and then definitely the online classes are a big boon over the offline classes. There is an academic briefing which would be there in the app what you are using to watch the classes. Just watch the academic briefing of your group and you will come to know the entire story. Now what I'll be doing is, since you are going to have another class, so I'm just stopping this live stream here, and I would be answering your queries through the voice note received on